Coming to what has been developed, we all know gemcitabine is used in a higher doses. That time the cost used to be around 30,000 rupees. The original molecule which was available, the cost has come down. So what we try to do, rather than giving 1200 milligram, give 250 milligram of gemcitabine in the extended infusion, and then see does it work similar. And yes, it looks like it works similar, suggesting that if you are able to give gemcitabine in dose of 250 milligram per meter square, then they behave in a similar way as compared to when you give in full dose. This is non-inferiority p-value, so it's not a superiority p-value. That's why it is significant, meaning that you have similar. The another work was we had a maintenance trial at that time for a drug called pemetrexed, and we know it is injection. That time you had erlotinib also approved in maintenance in lung cancer in adenocarcinoma. And we tried to explore oral tablets, easy to give. Does the patient behave to be maintenance of oral erlotinib as compared to pemetrexed? They have a similar outcome. Again, highlighting, it looks exactly similar. I know I do have a medical oncologist colleague here. There is a data, and that's not from India, that's from Western world, called trial, where erlotinib was not non-inferior to chemotherapy. So there is a possibility that in a different group of population, people do behave differently, as we know in many other situations. So, but in our data, it looks like if you give erlotinib or you give pemetrexed as a maintenance, so they behave similarly. Again, it is older work. Nowadays, significance is less because this is something which has come up in a big way as far as the lung cancer is concerned. This was our initial work. This was a time when we didn't have EGFR mutation kit in our country. If you import it, you have to get this arms kit. It is to cost around 25,000 to 30,000 rupees per sample. So we got our act together. This was a summer training who was working with us, Abhishek Kanamani, and we developed our own kit. What we did, obviously, so we developed a kit where in a poor patient, we could give this test in 700 rupees to patients if they are poor. So what it meant that every patient in our hospital at that time we could do EGFR mutation. What it did, it gave us our first work to suggest that what is the incidence rate of EGFR mutation. Till that time, there was only one paper that was from Tristar lab, which suggested that EGFR mutation in our population is 55%. Looks like our data is correct. And subsequently, there have been around a dozen publications suggesting that EGFR mutation rate in the Indian population remains around 25 to 30%. Now we have a database of around 9,000 patients suggesting the same numbers what they show. In our hospital, so that allowed us to do this randomized trial. And when we did this randomized trial, that time there was only one study which was published in NHM, and that was IPAS study by Dr. Tony Mock. That is tablet, that is targeted therapy, better than chemotherapy or not. What we did differently, we chose the best chemotherapy with maintenance at that time, which was available, which was not the case in IPAS study. And what it showed that in our population also, as far as the disease control is concerned, it is better than chemotherapy, but overall survival is similar what we have seen in overall studies, but overall survival was around 20 months. Highlighting the change which has started. Remember, we started with 8 months with whatever you give. Now, if you're able to have those targets, you're able to give targeted therapy, then the median survival can be around 20 months for this population. When we did it, we also realized we need to have more molecular profiling data for our patients to know how they are going to do. Putting this data in perspective, We got a bit late. We had many other studies which came in between. We started when it had, this data had come, but by the time we completed single center, so our next goal was to see that what kind of molecular profiling our patient has, because that is important. How you are going to have the drugs for the patient, and also in future, if you want to develop the NGS and you want to have a library for it, if you know what is the mutations, you can do this. This is our work which was done in the collaboration with Dr. Ambedkar. He is my basic science collaborator, and he was a PhD student. Dr. Pratik is now my co-consultant in my in our medical oncology lab. And what we did is we had our own pie chart. And pie chart for our population, around 400 odd patients sample. And what it will look like as when we compare with the Caucasian population, it looks like mutations are similar, proportions may be different. And for his PhD, he had a discovery which he finally validated that in adenocarcinoma, they could show first time that you do have a FGFR mutation in this population. Subsequently, we also worked on our squamous cell carcinoma patients. So this was adenocarcinoma. That gave us a hint of what kind of mutations you have. So we could make NGS panels for our patients, which we finally made it. In the meantime, we were working on squamous cell carcinoma. What kind of molecular profiling these patients have? Again, working with my dear colleague, Dr. Amit, he is PI in abstract. And what we can see, the different kind of mutations you have, what we see in our population. Bit different here. We had in our previous database also the squamous cell carcinoma patients having EGFR mutation. And that time, if you remember, Manish is here. NCCN, this is not acknowledge that the squamous cell carcinoma patient has EGFR mutation. And our paper in 2011 or 12, we had that 4% of our population does have a EGFR mutation patients. And we continue doing in our lab. And again, when we did this molecular profiling by NGS, it suggested the same thing that yes, we do have EGFR mutation in our squamous cell population. Apart from that, you did have some other mutations for which you do have some little drug, but squamous cell cancer patients, you do have mutations in good number of patients, but for the drug, we are struggling and hope in future we do have. But what I wanted to convey you, yes, now NCCN does acknowledge, and in fact, NCCN does acknowledge not in selected patients. It can be, you can do molecular profiling in any squamous cell carcinoma patients, because now the recent data suggests from more than one center that you do have EGFR and other molecular changes where one can give treatment. Showing the same data in a different way, having those mutations showing in a different way for same squamous cell population. Almost 450 odd patients were as a part of this work which we did. Another work where we were doing it, when we do work, we keep getting some interesting things as the time goes by. And this was one group of family where we had lung cancer patients. I had not known that lung cancer can run in a family, and here it was happening that it looked like they were non-smoker, and yes, there were 3 family members who had lung cancer. And that gave us a chance, and this was the PhD thesis for this student. What we did whole exome for all 3 samples, and in all 3 samples we had a gene, what we see here, that was an HER2 mutation, 663, which was that time not so known that it happens in lung cancer patients. The same person, what he did in the lab the work to see that if we inhibit, we give the inhibitor for HER2, does it work? And what we can see, yes, it does work. Out of 3 patients, 1 patient died, 2 of them, we could give them the HER2 inhibitor, and both of them responded to the treatment, highlighting that yes, if the resource is not a concern, you do have molecular profiling for an individual patient. It can give you a data that you can intervene and it works for the patient. As we have more data going on, we did have double mutations, and this is always a concern that if you have a multiple mutation, how do you handle? I can't say that we know for sure. This was our initial experience when you have an EGFR and KRAS. Now, which supersedes? We think KRAS is a resistant mechanism for EGFR inhibitor, not necessarily EGFR inhibitor may work, and we don't have any KRAS inhibitor. We get to all 3 patients, the EGFR inhibitor, and it looked like all 3 responded. So this did, for this situation, you have a data which is conflicting in the literature, but suggesting that if you do have a EGFR mutation with KRAS, don't avoid them giving EGFR inhibitor. You can give it. The problem is that you do have many other co-mutations like EGFR with ALK. What you're going to do? Sure, we can have a discussion in the panel. Another issue which I talked about, and this was, I told that yes, we kept doing EGFR mutation in squamous cell carcinoma patients from the beginning, and this was a clinical data suggesting that if you give TKI to them, they do better than giving them chemotherapy. And in multivariate analysis, the TKI was the most significant factor for these patients if you give them TKI with the squamous cell cancer having EGFR mutation. When we were doing this work, we also realized that when you do profiling, you get all kinds of different mutations which are not classical. And now we do talk about it, uncommon mutations in EGFR. This is one of our papers for different kind of uncommon mutations what we can get, and also suggesting that yes, we have started learning this uncommon mutations. Not necessarily uncommon mutation means that patients don't respond to treatment, but there is a varied response to the treatment. And what we see here, the overall survival varying from 2 months to almost 22 months. What it suggests that slowly we will learn that which of these uncommon mutations we should be treating with which drug, and which of them will be behaving like a classical EGFR mutation, and which will be TKI resistant, or if we get a newer drug, we may leave them and only treat them with chemotherapy. Now, this was the initial part. We know that we all wanted to make things better. A lot of development has happened in having the newer tablets, that is second generation TKI and third generation TKI. And this is the work all of us know, giving osimertinib not only controls the disease better, it adds life to the patient. Only 3% to 4% of our population can afford it. So that was the limitation. But yes, it is an excellent drug. And that's the reason we thought we need to develop a treatment which our patients can afford. So what we did, there was some subgroup analysis of the intact trial, or those era 3-4 trials where EGFR mutation positive patients who received TKI plus chemotherapy, they had done better. We know that those were negative trials because they were all comers, but that gave us an idea. And I had a friend, I'm sure some people know it, Tarun Puri, he is in LIRD. We got the initial data which was presented somewhere, which suggesting that yes, TKI plus chemotherapy is something which is meaningful in these patients. What we did, compared gefitinib, the TKI, to TKI plus chemotherapy in our population, and what it does, the cost of the treatment is around 3,500 rupees for our patients, if you combine. And this was the trial design. This was an oral ASCO presentation. In fact, it was the top 30 abstract in the oral ASCO. We had a Nature review, we had editorial, and we had a Nature review commentary on it. And this was the data that yes, the control of disease doubles and also survival improves. And so what we have for most of our population, so sure, the people who can afford osimertinib, we can give osimertinib, but people, those 95% of the population who can't afford osimertinib, who can afford 3,000, 5,000 rupees, Ayushman is good enough for them. You have an alternative with a similar outcome for those patients as compared to what you get from osimertinib. This is the same data, or not same data, similar data from Japan which had come, and again showing that as compared to gefitinib, you give chemotherapy plus gefitinib, there is an improvement in the survival. So now you have almost 8 options, and out of those 8 options, these 3 are relatively inferior to these 5 of them, and looks like this one may be the cheapest one as far as patients are concerned. I'm not saying one is better than other, but what I'm saying that yes, you do have alternatives, what one can use it in your clinic based on the data available for us. We know that liquid biopsy is picking up. It is one of the standard way of testing in the clinic for lung cancer patients for mutations. So this was our initial work to find out, are we able to do liquid biopsy for at least EGFR? We have not done for all the mutations. And it suggests that if you do it, the concordance rate in advanced stage is around 80%, which looks good. It was an NGS platform. Yes, so meaning that yes, one can implement EGFR mutation liquid biopsy in our population. And this is not the story only for EGFR, which I talked about when I say the outcome being better. What I forgot to highlight was we started with 8 months. Remember what we have around 50 months in this stage 4 lung cancer patients. And that's the difference our treatment has been. to another mutation, that is ALK mutation, again well known, almost 5 to 10% patients have it. This is again our data suggesting that yes, if you give the first generation TKI, that is crizotinib in our population, then yes, you do have a median survival of around 35-36 months in these patients, where majority of them they are not able to take the third generation TKI. If you are able to give, which I am not showing the data, when we compared with the patient taking crizotinib and able to take lorlatinib, then the median survival is around 60 months. And yes, this is not our data only. This was a randomized trial suggesting that yes, if you give them first generation TKI, then median survival is 47 months in both the arms being similar, highlighting that. And remember, we started with 8 months, and that is where this 47 months or 41 months becomes important. You do have newer drugs in this setting. Many of them, not only you have alectinib, you have lorlatinib, and it suggests that they are far better than as compared to what we have seen earlier. And it looks like they control disease far better as compared to crizotinib, where they control the disease for 10 to 11 months. You can have a disease control of 34 months, looking far better. So outcome for these patients are than what we have seen with crizotinib. For ROS1, that is another mutations. What you have again, if you are able to give them TKI, they do far better than as compared to chemotherapy, and you do have a 4-year survival data for these again patients, where we have 51% patients surviving. Again, remember the lingo has completely changed when I was getting trained. So median survival of 8 months, and now we talk about median survival of 40 months, 50 months, 4-year survival, 5-year survival. This is not the lingo I was talking when I was getting trained for lung cancer patients. Do you have some more? Yes, you have a BRAF mutation where you can have a combination of BRAF and MEK inhibitor. It looks like almost 40 to 50% response. If you give combination in first line, almost 70% response. And again, you have a 5-year survival data for same group of patients, suggesting that almost 25% patients may go beyond 5 years in this population. Do you have some other? Yes, you have an anti-ARK inhibitor known as lorlatinib. There are other one also, and you do again have response rate data, and more importantly, you do have now median survival of 40 months again in this population, highlighting that yes, you do start getting group of patients where the treatment works far better. There are some more like MEK inhibitor, again response rate of 40% in those patients where they really don't have much options. You do have HER2 inhibitor, again showing response rate of around 40 to 50%. And this is our work which we did for poor performance status patient. I'm not sure of the whole, but in most of the government setup, and definitely for us, almost 20 to 25% of the population is in performance status 3 and 4. If you go by NCCN, you don't give any treatment to them unless you have targets, that is mutations are there. You need to give only supportive care. So what we did, because this is a big number, think about we have 2,500 new lung cancer patients they registered, and out of those 25% of them are performance status 3 and 4. So what we used to do, these patients, give them lorlatinib, send them home, tell them please come back if the performance status improved. And what was the basis for it? Some of them EGFR negative patient lorlatinib works, but more important is we know that almost 25 to 30% of our patients will be EGFR mutation positive, and they may benefit. And it looks like that's true. You do have a patient if there is a EGFR mutation positive, which report comes later because you don't wait in performance status 3 and 4 patients to get the report, because by the time most of them will be dead, and they do very good. We are working a bit more on this to refine it. Let's see next time or we'll be presenting the data. But it looks like it worked for us, and we could select those patients who could benefit. So we can't have a discussion on lung cancer without immunotherapy today, and this is the mechanism, the way the lung cancer evades the immune system in the body, and that's the reason you do have a checkpoint inhibitor, and we do know you have a PD-1 inhibitor, PD-L1 inhibitor, and CTLA-4 inhibitor. There are multiple data just highlighting from 2 data sets that how it has made a difference in the outcome of the patient. So at 5 years survival, if you have a lung cancer patient, PD-L1 expression 50 or more, then at 5 years, almost 1/3 of the patient survives. If you don't, then 60% patients survive. But remember, in those 16% same data from same outcome from the different data set suggesting that yes, immunotherapy works, and you do have 1/3 of the patient, if they belong to PD-L1 50% and more, they go beyond 5 years. This is our own data which we published recently for immunotherapy. This is a bit of all kind of patients. We are analyzing it further. Now we have a data set of around 1,000 odd patients. This was the initial publication. And what it suggests, if the patient they respond to immunotherapy, they keep going. And that's what we know, that if the patient responds to immunotherapy, 75% of them they won't fail. They keep continuing the treatment, and they keep. This was showing also that we also try to see, because good number of patients, I won't say very good number of patients in poor performance status where they don't have any option. They were interested in trying it. We did try it. Again, highlighting that their outcome is really poor. You see the median survival is 2 months. But again, you start getting those tail, what we call about as far as immunotherapy is concerned. So you have some number of patients who start going long term. So some patients may benefit in poor performance status also. We have tried to. We know that again immunotherapy has an issue. An issue is not the efficacy part. It is a fairly effective treatment, but it is. I always call my patients. I tell my patients it's obviously costly. And then we have an obligation that to develop some treatment which can be effective for our patients. And this was a review article on this because we are trying to explore which way we can make it cost effective. The company is not going to listen to us. No one is going to make a newer immunotherapy in India. It's not going to come out somehow. So, good thing is that what it taught us, yes, we do have a pharmacokinetic property for these drugs, which can be manipulated to make this, to administer this drug in lower dose and extended duration. Means that you, rather than giving 15 days, you can give every month or every 1.5 months. Rather than giving 200 milligrams, you can give it 20 milligrams. And we don't know it works or not. We have tried in some patient. I can't share the data at this moment, but yes, we are running it. So this is a trial which we are running, which is CTRA registered. We are enrolling the patient, and the dose of the drug is 1/10 of what we give to the patient routinely. Let's see what happens. If it trial comes positive, we do have a very good alternative to our patients. So in conclusion, there has been significant development in management of lung cancer. Targeted therapy and immunotherapy has significantly improved the outcomes. It is important to develop diagnostic tests and treatment protocol at local level. That's very important, and I think so. That's what we need to do more if we want more of our patients to benefit. There are many other developments which was not covered in this presentation. So lung cancer is a big topic. You have a whole conference of 5 days, 7 days. So absolutely I can. But 2 things to remember. Tobacco remains most important because in Indian population also, and that may help most of the patient. And second, as much I showed the improvement, that was a sobering effect because I had a patient of 25-year-old. He was an engineer professor, and when he talked to me, as usual, as a doctor, I talked to him all good things about the treatment, how it has improved, how it is better. But how it is better? How it is better? I was saying average life 5 years. That's what I was saying to him. I was saying, hey, initially it used to be around 6 to 8 months, and I was feeling good about it. He pointed out, doctor, I'm 25 years old, and that was a sobering an experience for me, and it keeps coming back for me because I keep seeing those younger populations. We have a fair number of younger populations who comes in 25, 30, 40 years age, and we are happy saying about that. Survival has improved, but again, that's why I say looks like glass is half full. But yes, something in the acknowledgement to many people. These are all students some from my lab, mainly from Dr. Amit, the others lab, all molecular work. What you see, very dear friend, dear collaborator, and excellent human being. My coordinators, they work pretty hard. My residents, my consultants and collaborators, Amit, Vijay Patil, Amit Joshi, Vanita Narona, Nandini Menon, Pratik. He was a student, come now co-faculty, was student of Dr. Amit, now is co-faculty, and Dr. Indraprastha Apollo, This is what we call my medical oncology molecular lab, and I keep saying this. They have taken it to the heart. Beti Padhao, Beti Bachao, all of them female. So, when you do studies, everywhere it is true, especially true in India, you will land up in hot water. And then you require all your mentors to be there to help you out and get out of the hot water. Perhaps my teacher, he was head of department, now he's academic director, and I'm sure all of you know him. He's Dr. Badwe, he's TMC director, absolutely wonderful human beings who allows us and guide us to do all this kind of work. My acknowledgement and for my collaborators, some of them which I have worked with, they have been kind to me. Thank you.
So, KP, I have 3 questions. First of all, it was a wonderful talk. I think it made my day, it made my trip. Amazing work you're doing. I really enjoyed that you keep bringing back Jepitinib at a low dose. And I think you've carried forward in all types of lung cancer, head and neck, and so forth. My first question is, are you doing the whole genome sequence or the exome sequencing in your lab? You have a molecular lab that you do, or you set up?
So whole exome, at this moment we have one machine. We don't do whole exome in our lab, but analysis of data is done in our lab. So bioinformatics is done in our lab, but development of whole genome, development of the whole exome is done outside. No. All the data I showed for whole exome was done outside, but analysis was done in our lab.
Yeah, because I was thinking, could you develop your own scalable and marketable kit that you can use across India? Because there is a lot of variation in how the test is being done and what is the payer mix and who can pay and afford and so forth.
So it is possible. So one of the important aspects remains how much is the institution invested in it. So that requires the institution to invest in it and willingness to do it. I'm a clinician come researcher. So what I want to do, I want to answer a question. And if you can give me part of the answer, I'm happy to collaborate and get that answer for it. But if the institution wants to develop, if you say yes, it is possible, I have no doubt about it, because this is one area I have been part of the lab for last 14-15 years. So I know that it is willingness and investment needs to be there. Resources to do it. The main work of mine, answering a question, takes a backseat, and then you realize after 30 years, because we all have 30 years of my work as we was so that is where we have. I mean, up to in person, the challenges in Indian context is you have wonderful things, but there are 2 wonderful things and 3 wonderful things coming together. Usually unheard.
Well, it's possible. So that's good. My second question is pertaining to your tumor proportion score. You mentioned in the context of pembrolizumab and the efficacy of more than 50% pembrolizumab or the TPS. How are you doing your TPS in your lab, and what type of tissue acquisition you are asking your CT or interventional radiologist or interventional?
Very, very important one. So what we do, we learned it with hard way, not for TPS. We learned it when we were doing EGFR, getting tissues to be challenged, and then we have now some set way of working that we mainly it is by CT-guided biopsy, because we have wonderful interventional radiology department. Our chest department, they do a good job, but they are willing to concede to our interventional radiology department to do so. But I do know it can happen both ways. So when they do the tissue biopsy, whichever way they take it, either a chest physician or interventional radiology, the key is for us to take multiple rows. So we avoid taking single row. What it does, it allows us to have a tissue, which is multiple row, and some can go for pathology department, some can department is same, but go for pathology work. some can go for molecular work. So there is an adequate tissue for the work. Second part is we don't have on-site evaluation. That is, we are lacking. And that's why we end up having this issue of almost 20% patient where we don't have adequate tissue for molecular work, which also affects the PD-L1 testing. But that we are living with because pathology people willing to be there at this moment, it does not happen. So that becomes the limitation. But 80% people, we are able to get those adequate tissue with this small little intervention.
So that dovetails into my follow-up question. You're talking about doing sampling from the primary mass or the tumor rather than the metastatic site?
Wherever. So if it's a liver, again, we ultrasound guided or CT guided biopsy. So that we don't only go for primary, wherever easily accessible site, we take the tissue. So we don't get into that. We have to take from till this moment.
My last question, and thanks for taking my questions, about Jeftinib and your low-dose protocol. How successful you have been in penetrating this model across institutions, specifically targeting the patients who can't pay?
So it is a part of our, as far as Jeftinib plus chemotherapy is concerned, it is part of, if anyone wants to go, if they update as a guideline, up-to-date as a guideline, it is a part of the up-to-date guideline. If you take ESMO Asia guideline, it is a part of ESMO Asia guideline. If you take ESMO guideline, it is a part of ESMO guideline. If you take EBM guideline, our own guideline of NCG, National Cancer Grid, it is a part of that guideline. What we believe, and when I talk to my colleagues, majority people concede that hey, if you can't give osimertinib to 5 to 7% of the patient beyond that. So it becomes a good alternative. I haven't done the survey that how many people give it, but it looks like there's a fair acceptance as far as that chemotherapy plus Jeftinib is concerned. Because what we have seen in India, that the moment you have something cost effective, people do the rest of the job. Then you don't have to do the job. And the best model is the Hindustan Unilever Limited. You make a shampoo in a bottle, it doesn't sell in villages, make in pouches, it sells in villages, and 50% of their revenues from villages now. Because they understood, make it cost effective, and you realize that people do it. So we don't have the second part of the capacity to go and letting people know that this data is there. That part we do. We put in many places that this data is there, but we hope that if there's something cost effective, people will pick up. So, but your point is valid. Most of the good grants, they ask for it, that after developing, you need to put things in place so that not only this dissemination of data is there is an uptake. Low-dose immunotherapy, we are working on it. That data will be, the first data for head and neck hopefully will be out next year. Lung will take some more time. Let's see when the data, I don't know about data. We have done even some off-label. Looks like, let's see, unless we have data, once we get data, how the uptake is and how the data looks like. We are taking our fingers crossed that will be, if it works, this is we are using for the second time separate model for developing a drug. We are trying for one more drug, but if we are worried about this, let's see how it comes out. If it comes out, then we know that we will be able, we can do multiple works with this using pharmacokinetics and scheduling the cost.
Well, thank you. I do have a question about that, but we'll talk.
Thank you. Do we have time for brief on shoot?
So you said that as you will explain and you said double mutations, right? So if there is a patient with double mutation like KRAS and EGFR and it's a smoker, then what would be the expectation? None of these patients were smokers. All three patients were not smokers.
So I know what Manish is trying to talk about is you have a smoker and KRAS. What happens to immunotherapy in that situation?
No, I'm talking about EGFR and KRAS mutation.
Mutation both is there, and KRAS is a smoker. I got it. And KRAS is now troubling me. If I give TKI, what happens to immunotherapy? So what we have observed, not only here, and some more patients, that they respond probability I will end up giving TKI because TKI followed by immunotherapy is fairly safer than immunotherapy followed by TKI. So smoker or non-smoker, that will. I'm concerned about KRAS driving. I'm not concerned about smoker, non-smoker. We know there's a bit of a difference, but TKI works.
So we understand that RAS is a downstream signaling pathways. TFR inhibitor, but RAS is also mutated. Yes, perhaps TFR inhibitor is not for TKI may not work.
I totally
Especially in a smoker. Because the data that you showed were all three patients were not.
I take the point, but again, I say we are emphasizing for smoker here, but your downstream pathway is KRAS. So it looks like many times I agree with you. In fact, I had a discussion with my and by the way, the paper was the corresponding author was my basic scientist guy, and we had this discussion about it. And he said, "Hey, how it is happening?" And then I said, "Hey, the hypothesis you are saying it." So we plan to do some work on it, but we haven't been able to do it. But I'll say, no, I do agree. It looks like in self the way you are saying. But looks like maybe that's the hypothesis which we need to not necessarily completely agree because that's only the book it works like this.
Yeah. So actually, I have a lot of questions. So, FGFR mutation data was quite interesting. 3% is a good number. Did you look at which FGFR? Is it 2, 3, 4, 1, 2, 3, 4, which one?
FGFR 3.
There was some data on FGFR 4 also.
FGFR 3.
Other fertility attacks only 2 and yes, it doesn't track 4. Yes. So from that intent, I was trying to see we have the data of FGFR and which FGFR.
It's FGFR is not the same as the mutation. That's the fusion where you're atrafin.
Yeah.
That's the fusion where it works. So
it is not the
it's
same.
not visible.
It doesn't say.
There's some data for puzopanib. That time we kept trying. We couldn't convince Novartis to understand.
HER2 mutation actually has hardly any activity. When there has been trials, you notice that there is some activity of FATNIP.
HER2 mutation.
You showed some data about FATNIP and neratinib.
There's some, okay, I take the point. So I agree with you now, especially with the newer drug coming, TDM and deruxtecan coming in. But we do have some activity, and I take the point. I'm not saying that's the only way to do it. But HER2, which I showed you, was the data from the individual patient. That was a specific HER2 660D mutation. In the cell line, it acted. So it acted, so we gave it to the patient. Yeah. So again, the issue that we generalize a lot, but slowly we learn that not necessarily what we generalize is specifically true in every situation.
So when this data combining gefitinib and chemotherapy came in, and I remember it was a Tony Moss fast act study. There was an editorial, don't act very fast. The concept was of intercalation. That means you put the gefitinib off for a while, give the chemotherapy, and you start gefitinib bit later. Do we need to follow that still, or that concept is gone? The concept of intercalation of gefitinib with chemotherapy, then starting chemotherapy a bit later than chemotherapy, and then stopping it before the next cycle of chemotherapy. That was the concept of intercalation of gefitinib with chemotherapy.
So, if I remember last time, they had taken all comers.
They have taken all comers.
They are also in the mutation positive patient.
There was
I'm not saying that this is the only way to do it, but at this moment, data is for combination because now there are 4 randomized trials.
Do you need to stop gefitinib and restart, or you just give it continuous?
For us, we haven't, because there was some a bit more toxicity, but not a big one. Less, it will be similar to what you give chemotherapy. If you give alone chemotherapy, it will be similar. So it will not be adding gefitinib. As compared to gefitinib, toxicity will be more, but as compared to chemotherapy, it won't be pretty high. So intercalation is a good idea. I have no doubt about it. That allows the chances of people to have, not from efficacy point of view, because I have seen the data for the efficacy. It doesn't look like something dramatically different. In fact, this looks far better than other one. But safety point of view, there is some merit to it. It can be done. But all the 4 randomized trials which has been done, they are in combination. They are not being intercalation or sequential.
Your thoughts on abnormal maintenance in squamous cell carcinoma?
So abnormal, I have no doubt. It works in EGFR mutation negative patient, including stem cell cancer, because we have worked on head and neck cancer. We have a JCO paper on abnormal plus methotrexate plus rituximab. In a platinum resistant patient, where almost 40% patient responded to treatment. So there is some merit to it for abnormal as compared definitely working in other situations than only nutrition or positive patient. And the best example is that the maintenance trial for Arlotnib. So Roche left it, I totally agree. But the trial when it was done in maintenance, it also worked in squamous cell there. But somehow when the trial came negative, it was abandoned. In fact, Roche got a label out of as far as those for this is concerned. But I think so maybe if you ask me as far as this data is concerned from our side, I think so they worked in haste for some other reason. Thank you, and I think so we are running there. Thank you so much.
Thank you, Dr. Prakash. It was a lovely lecture in which you recapitulated 20 years of progress of lung cancer in 20 minutes. Now I invite Dr. Ashutosh Sachdeva, our Information Facility, Director of Interventional Pulmonology Program at the University of Maryland Medical Center in Baltimore, and I invite him to talk.
Thank you again. And thank you again for organizing this. Congratulations. While I'm getting my slides up, I want to thank Apollo Hospital for inviting me. It's very close. The place is very close to me. My OCD passed away in 2019, and she got a wonderful care there, Dr. Sagar, Dr. Sudha, Dr. Chabra. So I really want to thank the place for all things that they did. My slides are up, and I think it should function. My topic is very interesting, and the only drug that I can talk about on oncology is the Dabrafenib, because the BRAF mutation is built in the drug name. So that's the only thing I can talk. So KP, you need to make simpler drugs so I can not have a scanning speech talk about it. My task as a pulmonologist seems very simple, but I'm going to walk you through the story of building a program and how we are the critical link between the thoracic surgeons, medical oncologists, and the radiation oncologists. I think I'm having a little challenge with this. Is it working?
Yeah.
So that's our institution, University of Maryland Hospital in Baltimore.
क्या वो से चल ही रहा है क्यों
Did we use the battery? Let's try it again. So are there any resident trainings in pulmonary medicine? I see that your total is faculty here, right?
सब ऐसा करेक्टेड है ना यहाँ पे ठीक है ये ऑडियो
subspecialties. So let's see if this works over here. I can pivot a little bit. Is it possible for me to get a computer over there? Yeah, okay.
यहीं से करवाना
I can wait.
ये दे दो
Yeah,
Order
I'll
send.
say next Wednesday. So I put this picture because I want you to understand that things are not as clear as what it seems in the picture. Right? You can see the butterfly in the mix of the greenery over there. When I start talking about interventional pulmonary, we don't have data like our oncology groups. We don't have a lot of studies that talk about survival, but we do have data about quality of life. We do have data about how well to guide to a nodule and how we can get better enough closer to CT guided beliefs of ours. So as I shed some light, things will get a little bit blurred. So be patient with it. This is a recent picture of our group. We have now expanded to 4 different hospitals in Baltimore. We started our program in 2012, and this is 2021. In 9 years, we have built on nothing. So I think that's a proud moment for us and my team, including my partners. Our discussions are going to be around the elusive nodules that our plastic surgeons frequently ask us to biopsy because they don't want to chase every nodule that looks like cancer. And then our oncologist colleagues constantly ask us, please get me more tissue next time. Right? Is that kind of the view that you told me? Yeah. Get some more biopsies. You didn't get core enough, or the number of cores was not enough. And we constantly look at how do I get better each time. And then our radiation oncologists and constantly be chuckling on behind that Zoom. They say we deliver the safest toxic treatment for cancer, and then we deal with the toxicity that happens. I think it is not going to go well without a slide because it's not challenging. Let me try. This was to highlight that there are different types of nodules that we come across. Some are speculated, some are round, and it's important for us to understand how we look at the radiographs. I think a lot of my colleagues think that we just go in there and sample, and it's very easy to do a biopsy. In general, there is not a lot of cognitive thought process involved, but that's it. They do come in various shapes and sizes. Are you doing something? So once a nodule is diagnosed, and I hope this is projecting well, and if you can see what is written on the slide, this is a paper from Michael Cole, which talks about at what point your threshold changes. And he beautifully illustrates that it depends on what is the pretest probability of a disease. So when you get a CT scan, can you say with high confidence based on the volumetric change of the nodule size over a period of time? Can you satisfy patients' need? Are they going to be constantly losing sleep over is it cancer? If that's the case, your threshold can change in terms of the diagnostic test you want to follow. If the patient prefers certainty, of course, it will shift. This area will go down to minuscule, and you'll have to offer some type of diagnostic test, whether it be a CT guided biopsy, bronchoscopy biopsy, or a surgical resection, depending on the location, size, and the skill set available, you will offer. Or the patient will get a second test, again, depending on various factors, cost, patient preference, and that would be typically a PET scan. change your decision threshold as well. Now we have evolved into doing additional tests that increase or decrease the pretest probability. We'll be talking about that. But everything revolves around this content or the context of what is your pretest probability you're taking into account. And once a decision is made that something needs to be sampled, I, as a pulmonologist, have to satisfy the need of 3 different individuals: the surgeon, and if the patient happens to be a non-surgical candidate, both the medical oncologist and the radiation oncologist. So the way I think about it is, where is the lesion located? And I think that's where the critical component is being able to review the images. How do I get there? And there, I think there is a lot of discussion to happen, and we don't have time, but you could use various type of platforms. You could just use CT guided, fluoroscopy guided sample. You could do electromagnetic navigation or virtual oncology navigation platform. Now we have another platform that is called CEON-based tomography, but it again uses some type of CT diagram data to be integrated. And then we have evolution to robotics that gives you better ability to articulate and change the trajectory of the needle. Once you have the roadmap, mental roadmap, which could be a very simple, as simple as knowing where the lesion is based on the CT scan. Thereafter, once you get there, you have to pick or choose a tool. What type of tool? Are you going to use a radiologist to confirm? Are you going to use a fluoroscopy? Does radiologist give you a real time or kind of a location sensor and where you make these relationships to where the probe sits? I'll talk a little bit about that. Or can you use a cone beam CT scan that is readily available at any institution, right? The CT guided biopsy is done using nothing but a CT scan, which is nothing but a sophisticated cone beam CT. Every interventional radiologist has multiple cone beam CT. You have access to those areas where you do a bronchoscopy in conjunction with their platform. And then there is a new platform that we have played with. Basically, it's a CEON-based tomography where you generate a fluoroscopic image and thereafter go on to generate a nodule tagging that can then help you decide how to deploy your needles. And then the biggest threat, right? Every oncologist is going to ask me over the past 9 years, the need for the testing has increased constantly. And for the best patient care, we need to make sure that we have adequate sterility. We're talking about, do you have rules? Yes, I do rules for every patient. So rapid on-site psychology evaluation. And then it's not just the usual PD-L1, PTFR, KRAS, DLK4, ROS1, but we have expanded mutation that KP was talking about, that patients with one of the patients had a BRAF mutation. Right? And then the discussion about double mutation. So how do I sample that? And that is what we're going to be talking about. A simple concept when I look at the nodule is where the nodule is located. And in this, any good pulmonologist will tell that this is located in the superior segment of the lower lobe. That was actually a quiz for the fellows. There were 2 slides. I'm still going to try to see if I can answer this slide. The fundamental question I am asking is, can I get to the region? And how is my tool or catheter or sampling device that I'm going to use, and what type I'm comfortable with, is in relationship to the nodule. This is a nodule, and there's a slight airway. We call it airway pump of non-sign, and I think we can debate about whether this means the airway has to go into the nodule, or could the airway just by swing by, and you see a large vessel curving into the nodule. How do I get into this right upper lobe anterior segment, which is located medially, because most of my tools and catheters go a little bit lateral and stay straight. A critical component for young pulmonologists, I'm hoping that there are some residents and fellows, and of course our oncology colleagues to understand is that it's not that easy. Because when I get to the target, I need to really know which tool or catheter will give you the best answer. And there may be a needle that gives me an easy access, straight entry, because the airway is blocked. Or there may be a biopsy forceps that I can open and classic example of a CT counter sign, a very old paper talking about what a CT counter sign is. This is a lateral segment of the superior, the lateral subbranch of the superior segment, and there is no question. Anybody who knows compositely and close their eyes, go into this area and get it. You don't even need any technology other than a biopsy tool. Likewise, again, here, the superior segment, if you go into this medial subbranch and you get this oriented doing compositely, you're not going to get an answer. But you're in the lateral subbranch, as the scope rotates, you will have an answer. There is a case that I wanted to share. I'm hoping that portion of that will work. Fundamental to the understanding of sampling these nodules is this airway nodule relationship that is critical. Whether you're a young pulmonologist or a senior pulmonologist, and if you have interest in procedure, I think it's fundamental to understand this. Again, here, this is a cartoon adapted specifically to represent that when you pass a radial probe, which is right here, into the airway, you can have various formations of what confirms a lesion. And this is a lesion where the airway ends dead center. And our literature shows that this is probably where you have the highest yield, as close as 80%. Again, it's not 100% until now. If you have an airway that's blocked because it looks laterally, the radial levers, you can still have a kind of a partial concentric view, but if you try to advance flush, that may not go, and your best friend is there is a lesion where the airway goes around it, and you have an eccentric view. The fundamental issue there is the radial levers does not give us the ability to know where in the O-clock position does the lesion sit. And then you have a airway that is blocked, again highlighting that you could have getting on with too much spread. You may be able to get cells picked up on the flush, but that may not be enough because you're not penetrating the knot. We have to live with all these type of challenges. And the last one to understand is that if you're not getting a radially received, that does not mean that you will not be able to read. It is just that the radial levers cannot see forward, it can see laterally. And a lot of people don't sample even if they are confident that they are in the lesion or they are next to the lesion, that they have some type of information platform. I'm still wondering if I could get this somehow. My slides go, I think there would be a lot of information that I wanted to present in a way that makes sense. Because I'm a storyteller, so if the story is not right, you will not learn. This is an example of where the airway is sitting next to a nodule, and if you do a closer zoom and pay attention down there, any type of tool catheter is going to go away from the nodule, and it's not going to be able to penetrate. On the fluoroscopy, on the AP, and it's very important that people who actually do this go back to the administration and help them understand why you need technology. If you don't have technology, you cannot deliver care or the best care for your patients and ultimately your customer, your oncologist, your radiation oncologist. You need some type of catheter tool device to actually get there. I'm happy to take a pause if you are able to fix this. I think the way you're projecting the Zoom is maybe the way you're sharing. You should just share my slide set.
नहीं वो नहीं इस पर आई थिंक वीडियोस और ये होंगे शायद ठीक है प्रेजेंटेशन को वो नहीं कर सकते स्लाइड शेयर
So it's not it's just I think it's moving all the slides together.
वीडियोस presentation
It was picking up the animations before.
animation
That's it. So that's it.
disconnect
then we can have an informal discussion. I don't know if this will make sense or not. Or we already decided. Like so. So if you exit out and just share the PowerPoint slide, meaning when you do the share screen.
Yeah.
Yeah, see now it's working.
Okay.
So,
Okay. You have control.
okay, so I have control now.
ये देखिए running उस पर.
Did you run anything from this?
So.
Yeah. So on that screen is still showing the old.
change कर देना. ये अपने उस पर चल रहा है क्या? रुक नहीं रहा. ये रुक नहीं रहा.
So that screen is still stuck,
Yeah.
but this is working. So
Yeah.
that's- at least,
Do you have the control?
I have the control to
Perfect.
Yeah. Go ahead, but- Yes. No, it's online. Okay, well, I'm excited. We are back. Okay. So, this is a case where it's a pitfall lesion, as you can see, and we just talked about it. If you're trying to pass any catheter through, and if you have understanding of simple mechanics, this is going to find if it's a needle, it's going to look like as it's under the fluoroscopy, it's going to the lesion in a KP interpretation view, but that's not happening. That's where I tell my colleagues, I spend a little bit of do a little bit of brain work before my procedure, so my oncologist will at least have some respect that I as a procedure. Again, it's important to look at the coronal sagittal section. A lot of thoracic surgeons I work with, this comes very intuitively because they use this type of planning for their cases and so forth before they do a veg or segment technique, especially difficult cases. This is another example where the airway is kind of blocked. If I go back, you can appreciate that the airway tapers off, and there's another airway next to it. And based on my assessment before the case, I was able to kind of have an intuition that my catheter tools have to be defined previously. So there was an airway sitting next to the nodule, and there is no way that you can pass a needle that will not go just scrape off it. You may get lucky with a couple of cells, and you may think the next passes are going to give a lot of tissue to the pathologist. That's not true. Again, if you look in the sagittal plane, actually that's a coronal plane, there's a clear answer that the airway is sitting adjacent to it, not. This is a case where I actually use needle to get into it, and at that time we were using CyberKnife platform. I'm not sure what type of SBRT or IMGRT platform you have, but they were requesting fiducial placement, and we were performing those for the fiducial conference. Another case where you have these areas that is blocked, and if you try to pass a catheter, such as a brush that's blunt or a biopsy process, we are unlikely to get an answer. So again, there the needles are going to be your best friend, and you can use fluoroscopy to guide you, but again, giving you the directionality to get a more meaningful answer for this patient. Sometimes the CT scan does not give you the most meaningful information, and that's why you do bronchoscopy, right? You go in with this mind that I'm going to use, you do a lot of planning, catheter, what type of tool I'm going to use, what type of sedation I'm going to use, and so forth. But you get lucky and you can drive and see a small scope showing you abnormality. In my opinion, needle is the biggest invention in medicine. You can start from the very beginning, and that probably gives you the most meaningful diagnostic and clinical option. This is a use of fluoroscopy. I'm not sure what type of fluoroscopy you use. I'm always jealous of my interventional radiologists. They say, well, your yields are 90% not like ours. Well, I say you have technology that is much superior to mine. So give me the space and the team, and I'll tell you who's better. Again, this is an example where you can see that I'm using a guide sheet and I'm passing a radial probe, which looks laterally, and I know I'm doing a lesion. However, during the procedure, the needle is going away from it. So there was some change, both due to patient respiratory motion, we call it nodule hysteresis, as well as because patient may have coughed and my catheter may have kind of migrated to another area. But if I didn't have this confirmation during the sampling, I would not be able to say, oh my God, I moved. So I need to readjust. Many people think that the CT guided biopsy is a real-time procedure. The answer is no. They actually spin it 2 times to make sure the needle stays there. They do use a coaxial plane. So same way a pulmonologist needs that. Here again, the example you can see that a brush is going away from it, and I'm not doing it. Of course, we pivoted. This is an example of a 56-year-old never smoker. We have a never smoker team from previous cases who present with abdominal pain, diarrhea. I'm not going to go into the merit of the decision to biopsy, but let's say this patient did undergo, thought for failure to biopsy this or have the thoracic system taken. That is the only scan we had about the patient having this type of lung mass. Patient doesn't know, but had significant risk factors such as uranium, asbestos, and beryllium may not be for the lung cancer, but we don't know what other types of exposure. So the decision was made after the underwent of PET-CT that this was probably a low FPG activity nodule, but still concerning. And there were some radiographic characteristics in hindsight to that picked up. But the question at that time was what type of procedure we do when you have this very visible airway leading into it. This will commonly be called airway bronchus sign, and I want to just highlight 2 things about this issue. For example, when you move on to the sagittal plane, you can see the airways kind of on the side. And as you keep going further and further, I'm zooming it for you. All these airways are sitting next to the nodule, not going into the nodule. It's a critical piece of information because for my case planning, I had to decide that's my nodule behind the airway wall. It is not sitting inside the airway. And that requires a little bit of manipulation because you could do a needle that may not enter, or the cartilage may be quite reinforced in the superior segment. And there, I need to understand that if I pass a radial EVOS probe, which sits next to it, I'm going to get this eccentric view or a partial view that only gives me some confidence that is somewhere there, but I may not have an end-on direct hit on the target. So for that, the question is, how do I approach it? So of course, you confirm that it is eccentric, you have visualization that this is not a slam dunk and you have to pivot, right? So what else do we do? If you pass a brush, you're not going to get an answer. And you cannot penetrate a biopsy forceps to the airway wall. Otherwise, we as pulmonologists will be causing a lot of perforation, visualization, and that's not what we do, right? Even though lung is a very forgiving organ, we don't cause a lot of, we cannot biopsy the airway wall and fail. So what we need is a needle, and the question is there another way to access? And thankfully, over the past decade and a half, we have linear endobronchial ultrasound, which basically is ultrasound at the distal end of the scope. And a lot of our thoracic surgery, actually now most of our thoracic surgery trainees get trained under linear EVOS. They go through a hospital training under interventional pulmonary, and we have a pretty robust combined program. So here, I just want to highlight that there is another pathway that is shorter, and that's through this airway wall right here. So if I have the ability to see using an endobronchial ultrasound, I can do a shorter path and again penetrate the needle. I can see the cartilage, and this was a hamartoma, not a carcinoma tumor, which people were suspecting. In hindsight, we could see a little bit of a fat, and I think the confidence of the radiologist went up, and we then said, yeah, so you don't have to do that. This is again an example from McKinsey, who actually published it, but given every pulmonologist last, they're looking at for the shortest pathway to lesion, and here you can easily see it pass to the right mainstem without any lesion. So if we can do all of this, can we get to the small nodules? And that's where our radiology colleagues are very, very helpful. They have technology even in the existing platforms, whether it's Philips, Siemens, where you can actually do a 3D reconstruction and make a diagnosis. There is a patient that has a saddle nose, and in the history for the CT scan, it says patient with shortness of breath and noisy breathing. I think you will get an answer. And the radiologist called me, says, I have a beautiful picture of saddle nose. Does your patient have relapse in polychondritis? I said, yeah, of course. Can you assess tracheal stenosis and measure the length of the stent? I think we have platforms that are pretty good. I didn't show how we actually mapped out just by CT scan. We didn't do anything fancy. We didn't use a $200,000 platform or anything. It exists in your system. We just need to go back to them and say, hey, can you give me a roadmap for the cases I'm doing? And you get better and better at doing this. For us, we are lucky. I have had this technology since 2008, which is electromagnetic navigation. More importantly, what I learned is that if I have the roadmap to understand after I look at the CT scan, where the airway seems to be kind of going there, but not exactly where I have a lot of tone, although it seems proximal in the middle third, it is for me a very critical nodule. There's a lot of debate about what is critical, what is central, I'm not going to go into that. But to highlight an important concept there was only one airway that led into the lesion. And here I shared this pathway with our fellow right here. It should play. Can you play that for me? So, are you able to play that? Yeah, just okay. So basically, this is a platform where we generated a three-dimensional airway mapping and then created a path that tells me which airway I need to go into. And I can tell you this is the airway that was suggested by the pathway. I confirm forward to the radiograph. My confidence of getting into that gets better and better. So again, if you have the technology, you will get better and better at diagnosing the nodules. Unless doing a wedge biopsy is the simplest option in a high frequency probability. Again, you get a point of view. This is an example of a case where we can actually do enhanced platforms or fluoroscopic visibility. And this is a Medtronic platform where you actually put fiducials to remap where the lesion is, and you can track the lesion and correct for any nodule disturbances, and then use fluoroscopy to guide. Here, this is a great example where in virtual space it tells me I'm right there. I think I'm right there. I confirm with a radial levis, I have an eccentric view. I pass my radial levis, and here's my nodule sitting there. I can adjust my catheter and a needle sampling. I use an 18-gauge needle right here. It doesn't look like a needle because it is a little bit big, bronchus needle. And thereafter, I tried a long needle. I was able to better adjust and lateralize the catheter. And I know that's my nodule, and once I confirm it, and we have a diagnosis of an optimal tissue evolution. You can see how an extended catheter that comes from the bronchoscope articulates like this. Now you have robotic platform. So if I can account for all of this, could I also control my trajectory? And with robotics, you can do so. What it gives you is the ability to articulate, and it does a better job than your fellow training to hold the bronchoscope. And again, I don't want to blame everyone on them, but always be a better bronchoscopist if you can control by 1 degree or 2. And that's my platform. So we have a robotic platform. Those are my partners at Pickering. Van was the first woman in Maryland to do a robotic. We were the first in Maryland to do robotic platform. That's the team and my Blanc team who actually help us day in, day out. So coming to the next most important thing about medius timing, right? Everything is meaningless if you diagnose a nodule but you did not stage. Most common problem for us is patients get a CT guide biopsy, comes to thoracic surgeon, or comes to the oncologist, or comes to the radiation oncologist for treatment, but they haven't had a medius timing stage. And I want to spend a couple of minutes on that. And I think that delays the care because it takes time for somebody to get an appointment. I understand that, Avdesh was talking earlier that for cancer patients, NHS requires patients to have complete workup within 2 weeks. That's unimaginable. I think that would be ideal. NCCN recommends that your workup should be complete within 4 weeks. In the best of the health system, it could be a challenge. I know at Apollo, you could get an appointment the next day with Dr. Chawla and you would get a bronchoscopy same evening. It's possible. But there are system challenges that prohibit, and that means we have to evolve the system to work. For most of the oncology, thoracic surgeons, radiation oncologists know that unsuspected disease pathologically does exist in about 3%, especially in a nodule that has been tracked and the mediastinum is clean. However, if there is an N1 disease or a larger tumor size, and I'll come to another question that we need to answer, this can be as high as 20%. And I don't think any of one of us wants to go into the night with this level of confidence that there could be a possibility of mediastinal involvement. And then what type of treatment we need to decide for that patient will be coming in with a lot of discussion. This is an example where the FTP of this right upper nodule was around 3.5. The mediastinum was clean. We sampled the flora that was positive. The patient had comorbidities, and this was 3.8. To compound the problem, when we look at what we say how well we do versus what the data says. If I talk to 100 people in this room, what type of care you provide, everybody will say, I provide outstanding timely care. But the question is, do we really do so? And when we look at the data, this is the data from the SEER registry, where they do surveillance epidemiology. That's a national registry in the US. Let me go back to that. And then one point I want to highlight is that even in stage 2A, 2B, where surgery is the right thing to do, and even in 3A, 3B, that's what the talk is about today. There may be patients, but a quarter of these patients did not get mediastinal staging. And then Dr. Novish knows that patients who underwent mediastinoscopy, there was a great proportion. I forget 32 some percentage that the mediastinal sampling was inadequate. So we have better tools to get there, and why not use them? As of now, these are the guidelines. I usually stay away from guidelines, but this is a beautiful paper written by Jim Magoo, and he has highlighted this through a very simple algorithm. If you have a negative mediastinum and a clinical N1 central tumor greater than 3 centimeter or low SUV max primary, you need to do a tissue confirmation by EBUS DNA or mediastinoscopy prior to surgery. Either or is fine. I'm not going to go into debate about the cost, because in India, the cost of EBUS is 10,000 rupees. I'm just making a number, and the surgery is whatever. I don't know the number for that. That could drive it. If the cost of EBUS is, as in US, close to $20,000 US, you will say I can do bilateral luminectomy for that. The point is you have to have confirmation about it. If it is positive, of course, of some unique tissue confirmation regardless, and if that is a false positive, you go to surgery. There is a very interesting paper that caught my attention, again, from Matt Kinsey's group in Vermont. What they looked at was challenge the notion of this central and peripheral. Because if I ask the radiation oncologist, is this peripheral? That is not peripheral for them. That may be central. Because they're talking about airways. They're talking about preventing toxicity to the mediastinal structure. If you talk to a pulmonologist who does a procedure, they will say differently than a pulmonologist who does ILD practice. Because there are a lot of old school concepts that have to. What these guys did was very simple. They said, just tell me the location based on XYZ axis, and I will map it from the finite distance. What is interesting is that regardless of the tumor diameter, the risk of N1 disease of any metastasis was close to 20%. So what caught my attention was this tumor diameter of less than 10%. Now again, we need to see validity of this data in larger studies, but this was again a lot of patients from a lung cancer screening database, which means that you are a smoker. You just walk in to say, I have 15 years of smoking history, and I'm going to get a CT scan, low dose The other question that is evolving is, when I do a EBUS mediastinal staging, should I do a contralateral lymph nodes? And I think that's a burning question. There's very limited data from this group. They actually said, I'm going to retrospectively look at the prospective data. And for younger crowd, that is a retrospective analysis. This word prospective is very misleading. You didn't have a priori hypothesis. We didn't know what your end should have been. KP was talking about non-inferiority trials. We don't do superiority trials. They're very, very costly. And you need a very large N. So at best, what we do is non-inferiority, just a teaching point on a digression. They looked at their own cohort of 174 patients with clinical N0, N1, and and they followed methodically. So the study was well designed, the method was very appropriate, and they had a 12% of N2 on EBUS, which fits with the earlier data where it was 17 to 23%. But again, the point is we are getting better and better at reading sequence. What is in line with prior data is that 3% after undergoing EBUS still had N2 on surgery, and that may be institution specific and treatment specific. So I go a step further because we have a very sound relationship with our classes. They ask me constantly, can you get to this lesion so I can then palpate it? Because we are going more and more robotics. I was talking to Shoaib earlier. We were talking about whether you do robotic versus VAX, and that debate continues. But even if you do VAX, this becomes a non-palpable lesion. Now, Shoaib is an outstanding thoracic surgeon. He will look at the scan every day with the radiologist and be able to get. But what about somebody who's in 5 years into practice and they're developing skills? Can I make it easier? What if Shoaib has 2 surgeries going on and everybody's asking the clinic tech? Can I make it easier? The answer is always yes. These are just the example of various scenarios. So we have been doing methylene blue or indigo carmine depending on the dye. This is an example of one of our earlier cases. We injected methylene blue prior to the VAX, and then the patient underwent VAX, and we had adenocarcinoma. Typically, you can perform any type of guided bronchoscopy. If you're a skilled bronchoscopist, the robotics will tell you, drive a robot, you'll be closer to the lesion. The navigation, electromagnetic guys will say, and I say, hey, if you know your segmental anatomy and you have the right skills, you will get there, and you inject somewhere between 0.25 to 1 ml of the dye. If you inject too much, you waste the surgeon's day and the patient's day, because at least the indigo carmine, not the indigo, can be used with scope. That's why we have kind of shifted to indigo carmine specifically. You can use the fluorescence platform on the X side, if I'm saying correctly, it's the X side, like the robotics, into the platform, and you can actually highlight the green dye just with fluorescence. So this is an example where you only do the light at, I believe, 690 nanometers, and then it picks up, and then you resect and do the chocolate platform. Typically, most useful for robotic assisted bronchoscopists. So this is what I call the intersection of pulmonary and thoracic surgeons. These are my colleagues. Whitney Burris, who's been my awesome colleague for the past 9 years. Joe Cooper is our chief, is expert in myeloma. And that's our team with robotic bronchoscope. I'm not sure if it's work. We can try again on that you can put. So these are my colleagues. We are standing at our oldest medical school with our fellow doing robotic dance. If it doesn't work, it's fine. So the questions we typically ask is, where am I going? What is the safest approach? What type of tools and catheters could we use? And importantly for the oncologist, can we maximize our diagnostic needle, right? So it's no more about, I hit a needle and I'm lucky. And we'll talk about the best treatment part. So how do we go beyond needles? I don't want to go into the debate about which needle is better, mine versus yours, or 21 versus 22, or 18 versus 25. I think they all are the same. The question really is, can you go beyond it? So this is actually a earlier paper. Actually, this is a newer paper by Andre Gray, who was our fellow into our patients who have potential sarcoma, lymphoma, sarcoid, and lung cancer, and they devise this low-cost technique where you do a EBUS, pass a needle, and then you pass a left-to-property knife. This is a reusable left-to-property knife. This one, no longer available from a robust, so you can use a disposable knife, or if you have an institution to save it, it's only going to get more expensive. And then you pass a biopsy process, you see the biopsy process opening to that pathway, and then you are able to get better diagnostic tissue. So that's the comparative on the same patient. Again, I think there's an on that slide. Actually, this should represent a separate. Not sure why the animation is left. Or you could use a cryobiopsy. We have started using a 1.1 millimeter cryo probe and pass it to the target lesion, whether it be in the mediastinum, lymph nodes, or in the peripheral nodule, if you can get a mechanical biopsy process and you get a bigger chunk. This is my story of why I do what I do. This is the patient I saw in 2008. He aspirated hot dog on his 80th birthday. I was on call. My first year fellow had an in-service of cryo. I had never used it. I missed the in-service because I was in ICU. So again, you can't be at two places at one time. I called the surgeon. No offense to surgeon, but the story they heard was patient is an 80-year-old, sick, intubated. Oh, the patient's going to die with or without rigid bronchoscope. My request was the rigid bronchoscope. I think it must have been a bad day. I got my first year fellow and a respiratory therapist to show me, do my in-service. I thought I was a good skilled bronchoscopist. We actually passed and extracted this cryo from this background hot dog, and he was extubated conventional. And I think that day I decided I need to have more skills. I did everything right. So again, highlighting that there will be new techniques coming in. So if you do everything right, know the equipment, do the in-service, make sure you do it safely, and know what you're doing, you can help the patient. My colleagues, Dr. Mohindra, who actually, we have a lot of patients. I can do a 4-hour talk on radiation telemetry, but we collaborate with them to evaluate these patients before they get, if they're high risk, before they get therapy, and during the therapy to identify radiation telemetry. We commonly exchange our radiographs. It could be various patterns, various symptoms. It could be more organizing picture. Where do we need to intubate? Where do we need to biopsy these patients? And then they can get airway complications, and we need to intervene on these patients to get them through this. And there is a good bit of data that with multimodality interventions in patients who have advanced lung cancer and central airway obstruction, that their median survival goes up to 19 months with multimodality treatment. So I think that's a good example of where we have made a survival. Again, that is the p-value wasn't very significant, but there was a 10%. Again, a lot of one cases over there. And if you look at some of these patients may present with cough, asthma, or mucus clearance. That's an example where we had a near complete obstruction and a visualization. We commonly go back on the radiation plan. And I think if you're not familiar with it, Panji can explain a lot more eloquently than I can. But I look at these lines and the numbers. I ask him, where does your maximum drop-off occur beyond the V20 dose? And he tells me, we save these structures, we do this, and then thereafter I say, what would be the most likely? What this group has done is incorporated virtual bronchoscopy as a means to guide them. And this is all research, not in clinical practice, but I get excited about it because what it shows me is that they can generate a tracheobronchial tree just using a virtual bronchoscopy platform, and then figure out where the airways might be and try to save these airways using some type of airway protection factor. And in this example, you can see the pressure moving out to get the terminal airways gone. So they can actually adjust the treatment volumes and marking out these airways. And that's beautiful. And I think if this really, in a marginalized patient, gives them preservation of lung function without compromising the treatment for lung cancer, that is value added. So what do interventional pulmonologists do? We are part of the critical multi-D team, and I think if you are having tumor board every week, that is the right way to do it. We were having tumor board twice a week because we were having a mesothelioma program and a lung cancer program, and we have to expand from 1 hour to 1.5 hours. We are partners in providing patient-centered and value-based. People forget what a value is. You know, value is defined very simply. A water bottle on the street may cost 25 cents or 1 rupee. A water bottle at the airport will cost 500 rupees, maybe. I don't know the cost. But the value changes, meaning, so we want to make sure each patient is valued as a patient. And that's the big difference. This is our team at AVIP. I'll be chairing the education committee next year for annual conference, and you're very much invited. And thank you. That's a very good role. I'm happy to take questions, but if you want to move on, that's fine.
Just a single question. So we just showed a nodule where you approached the nodule from a different angle from the different airway. There was a distance between the nodule and the airway. There was a lung intervening in between. So have you had any like catastrophes? You had pneumothorax in between, or during the RE burst, you had some kind of bleeding. So just to know about the complications.
So excellent question. Lung is the most forgiving organ. We get insulted by the heart and kidneys. Right? Kidneys. We get insulted by the surgeons. I'm talking about lawyers, not the person. But it's very forgiving. We have had no complications going to the lung parenchyma. We tunnel at times using biopsy tools, using a bigger needle and then a smaller needle. If you go to the airway and you have compressed lung tissue, which typically happens when you put force on your handlebar of the scope, it actually creates some degree of epilepticus. We routinely go through, there is no increase with pneumothorax.
And no risk to your scope also when you flex it down.
So that is probably a similar risk as what you should be, the precaution you should be taking. So once the sheet is out, it doesn't matter how much you flex in. I would say we use a lot of force, but also I have a contract to scope damage prevention and so forth. But I think if your sheet is out of the working channel, and then there's minimal to no risk of damage. There is a damage that happens to the scope for repetitive use. We call it bending rubber damage. I don't think that's related to how you flex this.
Most of the Indian centers, these peripheral modules, if they are really peripheral, there is no problem. I think everybody gets a CT guide. In the middle, the radial EBUS program has really not picked up because of there is no electromagnetic guidance, there is no navigation. So, and the fluoroscopy also, the simple fluoroscopy is you need a C-arm. And not many centers have CR. So what we do is we do blindly and sometimes fluoroscopic guidance. That's another reason why so most of the people, they go for CT guided even if there is a little. This is the commonest practice most of the surgeons and physicians are following. And if there is with a PET, there is another area where they can, like if there's a left node, EBUS is not an issue. A lot of EBUS are done with the convex EBUS. Radial EBUS is really a problem. In the Japan, we've seen they have electromagnetic as well as fluoroscopy. Another thing guiding the rows, and they get diagnosed 90%.
So you bring up a very good point. I think Apollo has an innovation research program. The software is an open software, what we call, there is no patent on this. So if today you want to cover up a company, you can do it. The software is the key to navigation, right? Everything else is the tools catalyst can be developed. You modify a little bit, you can file a different path. So those are not things to overcome. It may take time, but yes, you're right. Should we be dependent on it? And that's why I showed you Jonathan Chelsea's paper. He went in, he said, I'm going to use electropolymer knife. I want bigger tissue. Why can I get tissue? And there's no other better way to sample 11L, 11R. You can't get through this endoscopy. A CT guided biopsy is dangerous, has complications. They will say no to you. So how do you get adequate tissue with the tools you have? The second part I want to comment is you don't need the navigation. I don't think the navigation platforms are there yet because there is a lot of epilepticus, nodule hysteresis. Unless you have a confirmatory platform, your diagnostic yield is going to be somewhere between the range of 70 to 85%. If you have all the tools, we just submitted an abstract to ATS. We used Siemens Spin, a 3D printer platform, and we demonstrated that where the navigation system was saying, civil triangles in a robotic system, the nodule was not there. I had to migrate my needle to get the first positive pass. We had to adjust the tool catheter. Yes, the articulation is perfect, it stays there, there's minimal buckling. So I am currently fighting, and I'm speaking on your behalf to your administration, if there is someone listening. You need technology. And if you don't have, so you can't have two worlds, like two Indians. You heard, people talk about it. You can't have an ECMO going on, but not have a CION platform, which is much cheaper. This is a challenge at my institution. I submitted a request for $500,000 capital purchase, and there are 3 forearms sitting there idle for 3 days a week that neurosurgeons don't use. Each one costs $1 million. And I go back and say, wait a minute, I think there is a problem. There are twofold problems. One, I don't have a voice that is central to what they hear, right? So the administration wants to hear what they're doing. How do they hear about what I'm doing? They hear about through the surgeon, the medical oncologist, the radiation oncologist. So if you function as a team, I believe you have a proton center, right? When proton center was open in Maryland, we kind of jokingly said, well, it probably consumes half the electricity of home. So, but it was critical to the strategic vision of the program, because if we didn't get a proton center, Hopkins would have got it. And Hopkins has a lot more resources. If they got it, there will never be a proton center at USC. So then Hopkins had to move their proton center to Washington, D.C. area. So strategically, it made sense. And it was the right decision that the leadership took. How does it help downstream to me? We get more patients. So if you have a collaborative program, you can leverage that. Not saying that one or the other decision is bad. What I'm saying is you need to start voicing your not concerns, but not complaints, but highlight your programmatic approach as a multi-team. I got recruited to the University of Maryland in 2012. Who hired classic surgeon? It was his efforts to bring me, not saying, and the money was going to the division of clinical. I'm part of the division of clinical care, but my biggest allies are classic surgeons. We are hand in gloves. I'm in their OR. I'm like all the time. I learned a lot from them. I trained their fellows. People ask me, why are you training the classic fellows? I said, absolutely. I want to train anybody who's going to practice, but practice it well. It's not about me, my ego. It's about who's going to be the next person going to take on the baton, and what's the succession plan? Who is the person who's going to keep building the program for the teams? So, and I think Gaurav and I talked with friends that but without this approach, even our administration focuses on highlighting lung transplant program. You'll see 20 advertisements for lung transplant, but maybe one for our but you'll see for lung cancer. So be a part of that team, and that's a challenge everywhere. It's not unique to talking over here as a pulmonologist. I'm talking pulmonologist. It's whether you go to Hopkins, whether you go to Yale, you pick up a center. Yes, Cleveland Clinic may be a little different because they have built on their transplant program. And then when went vertically downstream. I think we need to remember that the core of the program, there is another way to build this upstream. And that should be right.
Yes, sir.
For this wonderful lecture, the efficacies of interventional pulmonology, and as the requirement for a good bit and a good quality of tissue becomes paramount to the surgeon, to the medical oncologist, and to the radiation oncologist because of improving prognosis and lung cancer, the role of the pulmonary oncologist also rises. Thank you.
As we're running a bit late, we're starting out obviously in the platform, but we would like to move along to the next session. This is going to be the multidisciplinary decision-making, controversies and biases, and I would like to invite the session chairperson, Dr. G.K. Jadhav, on the dais to introduce the moderator and the panelists.
पैनलिस्ट में वो लैपटॉप ज्वाइन कर लो, उसकी ऑडियो भी आ जाएगी, वीडियो भी आ जाएगी, तो बस इसमें जाना तो आपके उसको कर देना पिन क्या मेरा एडिशनल को पीपीटी नाम से होगा ये
It is the future that calls us, our history that forms us. It is a passion that drives us for doing now what patients need next. Together as one, we pursue a better tomorrow. An ever-forward evolution of discoveries across boundaries, among partners, beyond failures, around the world. There are countless reasons why we do what we do every single day. But at the core, it is about our most precious gift: life. Life in all its beauty and its complexity. Life as moments to be experienced, shared and remembered. Life as possibilities beyond the horizon. Life transformed by science, from despair to hope.
how the concept of neoadjuvant treatment comes? Like all others, we like to see if we find that treating, giving the chemotherapy or the treatment before surgery has certain advantages. Like it treats early the treatment of the micrometastatic disease, in vivo assessment of the treatment response is better, identification of surrogate endpoint like overall survival, progression-free survival are there. There is also a shorter time frame to complete for clinical trials, which is one of the reasons why we started with neoadjuvant treatment. Of course, there are better tolerability of systemic therapy and identification of course, cohort of patients who respond better, better tumor biology. In fact, I need mine in the best most important. Better spin out the better. However, there are certain disadvantages, there are certain delays, risk of progression, no benefit predictive endpoint, and no survival advantage for therapy as well as early stage. So stage 1 to 3 is stage 1, the real early stage non-small cell lung cancer. So the major two important trials were SWOG is 9900 and MRC or PC trial, and they were surgery alone plus or surgery plus chemotherapy. In SWOG party was Acticarbo, in MRC or PC was cystatin-based chemotherapy. The point was that though there was a trend towards PFS and ways for the not statistical significance, and also the MRC study was no. Next slide. However, very recently, this study of meta-analysis of operable non-small cell lung cancer of 15 trials, which was published in Lancet, and there was 3,385 patients, and they found there was a significant benefit of pre-operative only technical problem. 0.87, 30% reduction of the risk of death, and they found that absolute survival improvement of 5 years is above 5%. However, there was no clear evidence of a difference in the rate of survival with chemo, scheduling, number of drugs, platinum agent, or non-platinum agent, or post-operative, yes or radiation, yes or no. So we know that neoadjuvant therapy does work, but we have a lot clarity. And most of the problem is that there was no clarity what sort of drugs to be used, because these all trials are very different. So this the trial, the NATCH trial, which is one of the trials required to treat this stage 3A, which is one disease, and try to give surgery, neoadjuvant chemo followed by surgery, and surgery followed by adjuvant chemo. So there was actually no statistical difference between these three survivors. So we can say that in at least in N1 stage 3A, the neoadjuvant and adjuvant chemotherapy is next slide, please. So what about the N2 diseases? Next slide, please. So there was some phase 2 data which showed that in the N2 disease, neoadjuvant chemotherapy does help. Next slide, please. So if we look at, I saw there were 4 major RCT between 92 and 2002. There was one trial by this is the US National Cancer Institute trial. There was stage 3A biopsy-proven N2 disease, randomized to surgery and surgery alone, followed by radiation, and or 2 cycles of neoadjuvant chemotherapy. This is the etoposide. They say that chemotherapy of arm has longer DFS and lower recurrence rate. The other study by Russell et al., there were 60 patients, stage 3A non-small cell lung cancer, mitomycin, ifosfamide, cisplatin every 21 days for 3 cycles for the surgery alone. They say neoadjuvant care will associate a significant improvement of median survival 26 months versus 8 months. However, if you can see the number really small, only 60 patients. So the other study, another study where they use cyclophosphamide, etoposide, and cisplatin, again 3 cycles for the surgery. The response rate was 35%, median overall survival was 64 months versus 11 months for surgery. But look at the numbers, it was so small, so we didn't actually pharmaceutical analysis is very difficult. The bigger trial was Becker et al., which published in BCO 2002. Whereas patient of non-small cell lung cancer stage G1B to 3A, 2 cycles of induction chemotherapy followed by surgery, followed by 2 additional cycles of induction chemotherapy versus surgery alone. In case of N2 diseases, they also receive post-op. So median survival was 37 months in the chemotherapy plus surgery arm versus 26 months in surgery alone. And the 3-year survival also favored the bimodality treatment. So this is about neoadjuvant chemotherapy. What about neoadjuvant chemoradiation? There are 3 major studies: the German study, the GLCCB, the intergroup 0139, and URC 089415. Next slide, please. If you cannot, I cannot talk. If you cannot go slide presented note कर दो तो वो
छोड़ो मैं कर देता हूँ. Leave it.
Next so this German study was an induction chemotherapy of 3 cycles of followed by radiation with concurrent carbohydrate radiation followed by surgery versus induction chemotherapy followed by surgery and radiation, and there was no significant difference in the 2 groups. In fact, there was increased rate of esophagitis due to radiation. Next slide, please. Intergroup 0139 trial, an important trial. They gave 2 cycles of neoadjuvant chemotherapy with radiation, concurrent chemoradiation, radiation versus surgery and consultation. So there was significant improvement in PFS in the surgical outcome. However, there was no overall survival benefit. So if you can look at this intergroup trial, so in one there was induction chemoradiation for the surgery, and there was chemoradiation alone. So they basically wanted to see if you can remove the surgery and be only chemotherapy. However, the surgical arm switch was very effective. Next slide. Last URTC trial, they use induction chemotherapy followed by surgery versus radiation alone, and there was also no difference in progression-free survival or overall survival. So in N2 stage 3 as a standard therapy remains chemoradiation. Next slide, please. So what we basically come to know about neoadjuvant chemotherapy or radiation? The treatment of patient with stage 3A N2 is complex and requires expertise from multidisciplinary process team. Neoadjuvant platinum-based chemotherapy followed by surgery is found to improve survival in patients with local advanced cancer. Neoadjuvant chemoradiation most probably improves. We know that it improves local clearance, and there is a strong rationale for adding radiation to neoadjuvant treatment approach. However, as of now, no phase 3 data really supports it. So the benefit of surgery following neoadjuvant treatment in comparison to definite concurrent radiation is unclear based on current available phase 3 data. So at least here we discuss and decide on whether neoadjuvant chemo or surgery versus. So in general, we practice if there is a single nodal landing stations, we can think of neoadjuvant chemo followed by surgery. But if there are multiple N2, then obviously it is definitely chemoradiation, and that's where our pharmacologists their role becomes critical. There is also evidence to suggest if appropriately selected, rigorously screened subset of this 3A patient with N2 disease, they may experience benefit from priority approach after resection with neoadjuvant chemoradiation. Next slide, please. So I think I have already covered this. Next slide, please. So these are NCCN guidelines. You also know there is either induction chemotherapy followed by radiation or a deputy concurrent radiation. Next slide. Now we will. This is what we already know, but now I'll briefly speak about neoadjuvant immunotherapy because immune checkpoint inhibitors is the flavor of the time. Next slide, please. Please tell me when to stop at this point. The rationale for neoadjuvant immunotherapy in operable non-small cell lung cancer that
50% or more patients are stage 1 to 3 resectable non-small cell lung cancer will relapse. And with perioperative chemotherapy, we have seen that actually 5-year overall survival is 5% patients alone. I have just shown the meta-analysis. And we also know that major pathological response has also been adapted as a surrogate endpoint in neoadjuvant trials. And tumor PD-1 L1 upregulation is critical for the spread and survival of metastasis, at least as shown in the animal model. And we also will show in the next slide the neoadjuvant immune checkpoint blockades shown a very good major pathological response, either in alone or in combination with chemotherapy, the rate of 20 to 50%. Next slide, please. So I will briefly discuss immunotherapy in stage 1, stage 2, and stage 3 resectable. For stage 3 unresectable, we already have Pacific trial, and that's not of my trial, but we know that for security, maintenance, global survival. Next slide. So, what single immune checkpoint blocking nivolumab, do we have any data? Can I have next slide? So, this publication by Ford in 2018, there are 22 patients newly diagnosed resectable stage 1, 2, or 3A non-small cell lung cancer received nivolumab based dose of 3 mg per kg, and followed by surgical resection, followed by standard of care treatment. And actually, it was shown that the feasibility nivolumab applied to lung cancer did not delay the surgery. There was safety only. One patient was more than grade 3 adverse reaction. There was one post-op death unrelated to study trial. Can I have next slide, please? So there was important slide is that 40%, 45% of resected tumor demonstrated major pathologic response post-nivolumab, of which 13% was clear. So this is something direct evidence that nivolumab or immune checkpoint inhibitor does work. Next slide. At the same time, there was also another drug, atezolizumab, which was being tried as a single agent therapy. So the study was LCMC3, and next slide, please. So the LCMC3 is a phase 2 study of atezolizumab in stage 1, 2, 3A for selected 3 resectable and untreated non-small cell lung cancer. The total number of patients was 180. The primary endpoint was major pathological response. They found in short that there was 19% major pathological response and about 5% pathological complete response. Next slide. So the 12-month DFS, major point highlighted, 12-month disease-free survival was 89% in the 39 patients with stage 3, and the 12-month DFS was 87%. So in stage 3 also you are getting a disease-free survival of 87%. Next slide. Once it is established that single agent immunotherapy works in neoadjuvant setting, they tried to do that dual immune checkpoint inhibitors. As now know that nivo plus ipi, they have a complementary and supplementary effect. So this study was neostar. So 44 patients, stage 1 to 3A, N2 single station, quadrilateral 2 and 4 nodes evaluation. The stratification was by stage. One arm only nivo, other arm nivo plus ipi. There was 3 doses followed by surgery and followed by standard of care. And primary endpoint was NPR rate in present treated with neoadjuvant of DV or nivo plus ipi. Next slide, please. So what we saw in nutshell that about in nivo plus ipi arm was 21 patients and 33 patients shows NPR plus PCR. Whereas nivo arm, the 70% patient shows NPR plus PCR. Next slide, please. Now, once this dual checkpoint inhibitors and single immunotherapy should work, what about immune checkpoint inhibitors along with chemotherapy? From our experience in lung cancer, we know that the chemotherapy and immunotherapy works better, especially in the patients who have a low PD-L1 score. One of the reasons might be that chemotherapy produces sort of a local inflammatory response. So this study, nothing study, look at it. Another next slide. So non-small cell lung cancer stage 3A, but a neoadjuvant treatment of nivolumab of
360 milligram plus Paclitaxel plus carbo every 3 weekly, followed by surgery, and followed by adjuvant nivolumab and follow. The next slide. So if you were to look at it, the major pathological response was seen in 34 out of 41 patients, which is 83%. And 24 out of 41 patients, there is 59 patients who shows complete response. So neoadjuvant chemo plus IO with nivolumab in stage 3 yields a complete pathological response rate that is higher than ever since previous. So this is really an important data. Next slide, please. So based on this very encouraging phase 2 data, we are now coming with multiple phase 3, of which I discuss only checkmate 816 because others have been on the actual phase. And EGM is one of the studies we are doing it on. This is one of the centers in India, Apollo, where I and Dr. Jati are co-investigator. We are looking at this data very carefully. It may have a paradigm shift in the way we treat our patients. Next slide. So Nivo plus platinum doublet, that is the checkmate 816 for resectable non-small cell lung cancer. Next slide, please. I'll just run through them. So eligibility criteria was resectable non-small cell lung cancer stage 3A, OBCOG performance stratified by stage, PD-L1 1% versus less than 1%, and sex. So it is 358 patients, 1:1 randomization. Nivo at the dose of 360 milligrams weekly. So the dose of Nivo is higher than what we use in medicine. We used to use 3 milligram per kg or 250 40 milligram flat dose, but in these cases they are using 360 milligram. With chemo versus chemotherapy only. Followed by so this is 3 cycles followed by radiological restaging, then surgery within 6 weeks post-treatment. And there is also an adjuvant option of adjuvant chemo with radiation, with a little radiation and follow-up. Next slide, please. Primary endpoint is pathological CR. Secondary endpoint are major pathological response, overall survival and active death. There are also exploratory endpoints like response rate and predictive PD-L1, AT and size. Next slide, please. So the if you were look at this CR rate, so it's Nivo plus chemo has a 24% pathological CR versus chemotherapy has only 2%. Significant. Next slide, please. So if the patient underwent actual resection has been the better CR with Nivo versus the injection which patient do. Next slide, please. If you look at it, every subgroup actually benefited, but if you have a better PD-L1, it helps. And if you have a KP of more than 12.3 per megabase or a PD-L1 more than 1%, the part move away more farther away from the midline for the response is better. But all subgroups, irrespective of the stage, squamous, non-squamous, PD-L1, PD-L1. Next slide, please. Next slide, please. Next slide, please. So this is the ideal study. I'm not going to because it is not yet published. It is neoadjuvant chemotherapy followed by surgery followed by durvalumab with or without durvalumab maintenance versus placebo. So in one group there is a patient gets chemotherapy with durvalumab for 4 cycles versus placebo with chemotherapy, and everybody goes into surgery. In fact, the surgeon has to certify that it is potentially resectable. Post surgery, the patient may get radiation depending on the requirement, or they get into durvalumab maintenance for a year. Next slide. So basically, neoadjuvant Nivo plus and chemo, they did show a very good response with improvement in care of RR. I'm not going to next slide. So yes, we think IO in neoadjuvant setting will work because adjuvant IO improved. We know, and consolidation IO also improved from passive star we know, and we also have seen that adjuvant and neoadjuvant chemotherapy are equivalent. So there is no reason why if adjuvant IO improves, neoadjuvant, and we are just seeing checkmate study that we have to. Next slide. neoadjuvant, this is the ESMO that was wrong, old. They are saying that neoadjuvant anti-PD-1 checkpoint is currently being evaluated. So I think in a year of time they will become a part of our therapy guidelines. Next slide. Only 2-3 slides about targeted therapy neoadjuvant setting. Next slide. So why targeted therapy? Because we know that IO is less effective in most component driven lung cancer. Subject Dr. Kumar has nicely shown this way. So effective shrinking of the cancer may clear lung tissue surgery and genomic testing has really improved. So we have now so many targetable genes. So it is only natural that we also try to see neoadjuvant. So these are some of the targets we can actually attack. Next slide, please. The patient with stage 4 disease are treated with biomarker guided personalized therapy or therapy with platinum doublet. And so more importantly, how do we change it? So why, if it in stage 4, we are using so many targeted therapy and in curative option we are still using chemotherapy. So these are the LCR leaders screening trial where people are basically local biopsy, tumor genomics, and basically targeted actionable driver and targeted study. There is a study that going on, and there is no actionable driver, then chemo plus IO for standard of care. 1,000 patients have been recruited. It's an US based study. So these are the different neoadjuvant screening trial with rate, ALK, PRAF, APR, also for example, for and these are all good. So we might have some exciting data. Next slide, please. These are the few trials which is going on. One is Nautica 1, which is ALK, ROS, APR, and rate cohorts, and they are getting treatment in neoadjuvant therapy. Next slide, please. And Neoadura, which is basically a patient stage 2 to 3 with placebo versus oxymetry plus chemo versus oxymetry trial. Next slide, please. And Vivato 001 is basically for a rate fusion positive and still is being tried. Next slide, please. So basically, the neoadjuvant targeted therapy we are trying to expand. Next slide, please. So in summary, lung cancer remains a formidable problem in locally advanced non-small cell lung cancer. Neoadjuvant treatment has shown promises and has improved survival. And the platinum-based chemotherapy doublet remains the standard of care. Neoadjuvant immunotherapy alone or in combination with chemotherapy hold promises. A neoadjuvant targeted therapy in selected patients with actionable driver mutation is an area of active research. And I think in a couple of years, we will see a lot of changes the way you are doing this. Thank you very much. I'm sorry I made this slide for a little longer now. Thank you.
Yes. Yes. Chalo. उनके बाद यहाँ स्लाइड presentation
Good evening, everyone. Can I start my presentation?
यहाँ से आवाज कैसे जाएगी वहाँ पे? हम यहाँ से बात करेंगे. We are audible, sir.
Yeah, can you hear me okay?
Yes.
Yes.
All right. Well, good evening, everyone. Thank you again for this invitation. It's a pleasure to speak with all of you. I'm sorry I'm not there in person, but I'm excited to interact with all of you. Again, the topic of my talk would be multidisciplinary care in modern radiation oncology. And my hope would be to tie where radiation oncologist stands in this entire spectrum of care that we are hearing about advanced lung cancer. I'm a faculty at University of Maryland at the Proton Center here with Dr. Sachdeva. I don't have any financial disclosures. We will quickly review for the non-radiation oncology audience just the available technologies for management of lung cancer. And then we'll jump on to how, from a radiation oncology perspective, we are involved in multidisciplinary decision-making for lung cancers for a few different scenarios. So just looking at the technology, conventionally, radiation treatments were planned with very simple treatment portals that were directed at the tumor, typically from the front anteriorly or posteriorly, and some other combinations such that, as you can see in the view on the left side, but that would result in significant extra radiation to the cardiac and other mediastinal structures. A more modern form of technology is IMRT or VMAT, where we are able to use very focused directed radiation beams that conform to the shape of the tumor and minimize the amount of radiation spreading around. And this next step in the technology spectrum is proton therapy, which allows even further conformality in terms of maintaining dose to the target. But unlike photons or X-rays, the protons don't penetrate through and through, and as such, structures beyond the beam essentially get no radiation dose. Another technology that we are using increasingly is stereotactic body radiation therapy, which allows us to deliver even more focused and targeted radiation beams to very small targets in the body. This was developed from using radiosurgery for brain metastases and brain lesions, and now the concept expands to the body as well. This is now standard of care for early stage non-small cell lung cancers that are not surgically operable because of medical or other surgical reasons. And we are also using this increasingly for oligometastatic disease sites. Partly, these technologies have been made possible because of improvement on treatment planning. We use 4-dimensional CT planning, so that way respiratory motion can be phased for different phases of respiration, and we account for that in the treatment planning. We also have technology for patients to do a voluntary breath hold so that the tumor movement can be minimized and targeted treatments can be delivered. On the treatment table, we are also able to take either just simple KV radiographs or actual cone beam CT scans, so we can see the tumor and make sure the beams are still targeting very precisely, even very small targets in the body. Another thing that we do with image guidance is continue to monitor the tumor response through the course of treatment, as we see in this example with the large right-sided locally advanced lung cancer. As it kept shrinking through the course of chemo radiation, we were able to monitor that and then account for modified radiation planning with the tumor shrinkage. So with that technological background, moving on to different scenarios where I, as a radiation oncologist, interact with other team members in the cancer team. Let's start with a role for post-operative radiotherapy in surgically resected non-small cell lung cancer. Area where the guidelines are very clear and the data is more strong is in negative margins and adequately staged N1 patients. There is no role for post-operative radiotherapy. In fact, time and again, different institutional and population databases have shown that radiation in this setting can actually be detrimental to outcomes because of concerns for long-term toxicity. On the other end of the spectrum are patients who have surgical resection with positive margin. Also included here are those that have lymph nodes with gross extracapsular extension. This is again an area where there is most likely the clear role for post-operative radiation therapy. Where the biases come in is sequencing of radiation with chemotherapy, with institutions doing either concurrently or in sequential manner. Our institutional bias and many other institutions do tend to follow concurrent chemoradiation in that setting as part of post-operative treatment. Where there is controversies and need for multidisciplinary discussion are those cases in between. Patients with close margin, or where there is a surgical unease and the surgeon's worried about possibility of residual disease, where there's parietal pleural involvement without possible chest wall resection, or those patients with high risk N1 involvement where there is multiple lymph nodes, lymphovascular space invasion, but an adequate nodal staging hasn't been done, or those N1 patients who are unable to get systemic treatment or have poor tolerance to systemic treatment and hence treatment stopped early. These are scenarios where it's a soft call and an extensive multidisciplinary discussion is needed to assess the need for post-operative radiotherapy. Where it's controversial is the status with N2 nodal disease involvement detected on surgical pathology. This is an area where conventionally we have offered post-op radiation because of institutional analysis suggesting survival and disease-free survival benefit. However, this has become more controversial, and we'll take a quick look at the data related to that. One trial that I would highlight is the adjuvant nevelbine trial, ANITA trial, which had a different question with regards to adjuvant chemo, but as part of a subset analysis, they looked at the benefit of port in different settings. Again, there was negative impact in well-resected non-small cell lung cancer. There was no impact or negative impact in patients with N1 who got chemo. But in those patients who could not get chemo, there was benefit of port. And similarly, in post N2 patients, there was benefit of port irrespective of chemotherapy. That led to the European trial, the Lung ART trial, which is modern data on role for port in N2 disease, where patients were randomized to control arm or conformal postoperative radiation therapy after resection and systemic therapy, either pre-op or post-op. And while there was some benefit in mediastinal relapse seen with the use of port, there was also increased incidence of death from unclear reasons that resulted in a non-significant improvement in disease-free survival. This study has thrown significant controversy in the role for port for N2 patients, and increasingly institutions are moving away from offering port. And that's the approach we've followed here at University of Maryland. Moving on, what do radiation oncologists have to offer in this setting? Again, using advanced technologies like IMRT and VMAT, we can treat the surgical resection bed and the stump with very high degree of accuracy and still be able to limit dose to the heart, the coronaries, and the contralateral lung. Proton therapy takes it even further step, and while allowing good dose to the target volume, it even further limits the amount of radiation going to the heart and even coronaries. And this is most likely expected to result in improved or lower risk of cardiac toxicities and likely reduced unrelated deaths. The other scenario that we often face in tumor board is the scenario where the tumor is potentially resectable, but surgery has not been performed. These are patients that are T3N1 with a very small node, or a small primary with multiple lymph nodes, or those that have T4 multilobar nodules, which are either node negative or node positive. Most of these patients would be lobectomy candidates with excellent performance status and very good post-op FEV1 predictions. Conventionally, these patients have been limited to non-surgical treatments with chemo radiation or chemo alone. But as we just heard from the talk from Dr. Panda, there is increasing use of neoadjuvant therapy with chemo radiation, chemo, or induction IO now. In all these settings, these are best done in high volume centers where there's surgical expertise to plan surgery after induction treatment. But this is an area where there are significant biases and controversies, and this needs extensive multidisciplinary discussion between surgical, medical, radiation, and pulmo-oncologists. Our bias at University of Maryland is to consider high dose induction chemoradiation therapy to more than 60 grays, so full definitive dose, and then consider for surgery. And what I would highlight for the audience members is the median survival for patients who ultimately go through trimodality therapy, these are all stage 3 patients, is 59.9 months. No data from consolidation immunotherapy or induction immunotherapy has ever reached this amount of survival in stage 3 non-small cell lung cancer. So what achieves this response? It's really the mediastinal nodal clearance. We've published our experience, and we found that more than the response at the primary tumor is the mediastinal nodal clearance that is a key prognostic factor, both for overall survival and freedom from local recurrence. And as we compare our data with other historical data for chemoradiation with lower dose radiation or chemo alone, and now with upcoming immunotherapy trials, like we just heard in the prior presentation, the mediastinal clearance is in the range of 30 to 40% with chemo, with low dose radiation, but with full dose radiation, we are able to achieve up to 60 to 87% mediastinal nodal clearance. And so that continues to be the bias in our institution, and for any patient that is eligible for surgery and is a lobectomy candidate, that's how we would proceed. There are going to be patients, the scenario 3, where the disease is unresectable. There is nothing that can be done from a surgical perspective, and those patients will be assigned chemoradiation therapy as part of curative treatment. The standard of care, and we'll hear about this more in our upcoming session, would be concurrent chemoradiation plus durvalumab. As radiation oncologists, we are using advanced technologies to expand the treatment fields and limit the toxicity. Where biases come into the play is the sequencing of chemo and radiation and use of sequential chemo or immunotherapy to be then followed by radiation or chemoradiation, which time and again has been shown to be associated with inferior survival than concurrent chemoradiation. Controversial is the use of consolidation chemotherapy before durvalumab, and under evaluation is concurrent chemoradiation and IO treatments. For non-curative poor PS patients, they can either receive sequential treatments or hyperfractionated radiation. So just looking at the radiation data in the RTOG 0617 study that looked at radiation doses, they also were able to analyze between 3D CRT, the older form of radiation, versus IMRT, relatively equal number of patients. And the IMRT was used for patients with larger target volumes, more stage 3B disease. And despite that, it was able to achieve reduced hard doses and reduced risk of grade 3 or more pneumonitis. So again, technology helps to make the treatment safer and more effective, potentially increasing outcomes. Proton therapy may allow us to extend that envelope even further. This is a case example that I treated where large primary, extensive mediastinal burden, but even contralateral mediastinal and hilar disease. These are the patients we would typically consider sequential treatments because the radiation volumes are so large. But again, using advanced technologies like protons, you're able to treat that, and this patient went on to receive even consolidation immunotherapy. Also coming up is use of concurrent immunotherapy with chemoradiation. So this phase 1 study with pembro combined with standard chemoradiation, no dose limiting toxicity was achieved, and the median PFS was well beyond 12 months with 1 dose of pembro and almost approaching 2 years with more than 2 doses of pembro given concurrently. It obviously comes at the risk of immune-related adverse events, something that our medical oncology colleagues are very, very careful in monitoring patients. So where's role for multidisciplinary decision-making in this setting? With our interventional pulmonologists like Dr. Sachdeva, we rely extensively on them for completing nodal mapping that can guide radiation fields. That way we do not have to do any elective nodal radiation, and we can limit the radiation volumes. Between the medical and radiation oncologists, we have to coordinate timing of treatments, simultaneously starting chemoradiation, and then also planning timely post-chemoradiation assessment so that durvalumab can be started in an appropriate time frame. Of course, we have to rely on extensive supportive care with nutrition and psychosocial support and pulmonary management. And then working with the pulmo and cardio oncologists, which are really new fields that are evolving to manage post-treatment care, and we'll take a look at that. So again, these are examples of radiation pneumonitis. Despite technology, some patients will develop radiation pneumonitis and will be symptomatic from this. This is a scenario where I would typically give Dr. Sachdeva a call and get his inputs and expertise with regards to management. As radiation oncologists, we are comfortable in managing these with steroids, but again, with IP expertise and pulmo-oncology expertise, they are able to better manage with a combination of inhaled and systemic steroids. That way, it makes our medical oncologists happy as well, that since patients can then be started on immunotherapy. Some patients will develop bronchial stenosis, and these patients, again, the IP team comes into the picture to open up the airways again with serial dilatation, which is a really critical asset and a luxury to have when there's a good interventional pulmonology team. Cardio-oncology is going to be increasingly relevant. We know this from breast cancer and lymphoma literature, but even in lung cancer literature, like this secondary analysis from RTOG 0617 study, and this analysis from WashU, cardiac dose was an independent predictor of overall survival and disease-free survival, with pretty much all dosimetric parameters of heart being relevant for overall survival impact. And so we are increasingly engaging with cardiologists who are trying to develop expertise with cardio-oncology for proper follow-up of these patients, and something that definitely in an integrated system like Apollo, with the resources available, patients can benefit from this. There's also a role for this multidisciplinary decision-making in advanced metastatic patients. For patients that come with post-obstructive collapse and consolidation, oftentimes Dr. Sachdeva and his team will help manage the airways acutely, and then we will follow these with post-operative radiation therapy. some of these patients will receive immunotherapy, and that's where we again integrate with our medical oncology colleagues so that we can time the palliative radiation appropriately. And for a very small proportion of patients, there is role for SBRT for oligometastatic disease so that we can improve their outcomes. So a data that I would like to highlight is the secondary analysis of Keynote study where patients who were receiving Pembro, if they had prior radiation, their overall survival was actually superior than the cohort that only got immunotherapy. And the reason this is important is because there is general fear and concern that maybe addition of radiation would cause additive toxicity, especially in pneumonitis. But if done safely and using proper technology, it actually results in improved immune response. And this is something that is actively being studied in many studies. In oligometastatic setting, there was this study from MD Anderson, Colorado, and Canada, where they did either surgery or radiation to sites of limited metastatic disease after first-line therapy. And to everyone's pleasant surprise, not only this improved progression-free survival in this patients with metastatic disease, but it also has been linked with overall survival. The study was actually closed early because of the significant benefit that was seen with the addition of local consolidation. Again, a role for surgeons to also get involved in the metastatic disease setting. The final scenario that I would like to highlight is re-irradiation. This is something that we have technically stayed away from because of concerns for toxicity. But again, with improving technology and the support of our interventional pulmonologists and radiologists who can attempt biopsy, open up airways, stabilize bleeding, and then working with our medical oncology colleagues, re-irradiation to definitive doses is possible, sometimes with concurrent or sequential chemo or IO. We've published our experience as part of a collaborative group for proton therapy, but similar experiences have also been reported just with IMRT. So this does not only require protons. This is an example of a patient that I treated for a superior sulcus tumor that was treated definitively. And as you can see with protons, we were able to significantly limit dose to the spinal cord, the esophagus, and the brachial plexus, which otherwise would not have been possible with conventional radiation therapy. Again, these are scenarios where we have to engage with our medical oncology colleagues and review each case to decide which patient may be a candidate for re-irradiation. So the takeaway point from this very brief discussion was to provide a radiation oncology perspective of how we can engage in multidisciplinary care and benefit from the expertise of our pulmonologists, our cardiologists, our surgeons, our medical oncologists, so that we can overall provide more comprehensive care for our patients. A modern radiation oncologist has multiple tools to make radiation treatment safer, from 3D to IMRT to SBRT and proton therapy. We've constantly continued to improve the therapeutic window. And by reducing excess cardiopulmonary radiation dose, hopefully this will result in a lower pneumonitis and risk of cardiac deaths, further improving survival. And finally, the care delivery in advanced lung cancer does require a multidisciplinary team to work in an orchestrated manner. We should be open to recognize our respective biases. We should embrace the controversies and should always challenge the status quo. There is always room for improvement. With that, I would end my presentation and I would be happy to take this questions either now or as part of the panel session. Thank you again for this kind invitation.
Excellent presentation. You know, it's like going through the whole radiation chapter and lung cancer in a brief, update. Any questions from the audience? Yes.
Superior sulcus tumor, I just want to know your field of radiation, but even if there's tumor, what is the subfield vessels? So what are your fields? What is the role which you do?
I'm sorry, but the audio is coming very slow. Would you be able to say that again?
For a superior sulcus tumor, pancreas tumor, which is placed anteriorly, close to the subclavian vessels, with the involved lymph nodes, no actual lymph nodes, what are your fields to do?
So
in the absence of involved lymph nodes, with involved lymph nodes, under those.
So if I'm understanding your question correct, for superior sulcus tumors with with N2 nodes or in absence of N1 nodes, how do we approach it from radiation perspective?
Yeah, and two nodes or without any nodes. My point is basically whether you electrically irradiate the higher node or do you spare the upper campus?
It's a great question. And I think this is where we actually really rely on our partnership with interventional pulmonology team and get a really good staging workup with a PET-CT at baseline. As it stands, if the PET-CT and EBUS is negative for N1 and N2 station lymph nodes, then we will not electively radiate the hilum and the mediastinal area. This is a little bit of a subjective call. If I'm treating the volumes and there is a small lymph node that's sitting right next to our target volume, then oftentimes as radiation oncologists, we'll slightly extend our treatment fields to treat that if we feel we can do that safely. If on the other hand, there is a small lymph node that's really far away and EBUS is negative, PET is not avid, then we will not extend the treatment fields. And this is especially relevant for patients who are going to undergo surgery. And I know Dr. Zaidi may be able to elaborate a little bit more about this yourself, right? That operating in a radiated field is not easy. And the least the radiation oncologists can do is to try and limit the radiation field so that the post-operative respiratory complications can be minimized. And hence, we do not do any elective nodal radiation.
Thank you.
Thank you, Raju. Excellent talk as always. I don't have a question, but I do have a comment. Can you hear me okay?
I can hear you, yep.
Okay. So I think you give too much credit to us, but I want to give it back, not because I'm a pattern of fact. I think our stent volumes over the past decade has continued to decline despite increase in therapeutic volume. And I think part of the reason is, and I suspect, I don't have proof, is the early intervention that we can do on these patients working with your teams. So they get, get to a multi-tumor board early on, get started on radiation treatment. We don't have to. So that's an important notation I just want to make.
That's a very fair point. And I think we do benefit from having a team that's constantly talking with each other, that's available to each other. And we can then make an educated decision whether this is a patient that would benefit from upfront stent, or is this a patient we should jump in with a short course of radiation and monitor very closely through your team and our medical oncology team so that we can decide whether a stent may be needed in future. And many of these patients we can get through without the need for stents, because as I understand from learning from you, the stents also come with some challenges, and many patients will continue to have cough and other symptoms locally because of the stent placement.
Go ahead.
Go ahead.
No, I blame the complaints that I receive from my trainees that they're not getting enough stent on conscience.
So even in the NCCN guidelines, there is no consensus on preoperative chemotherapy versus preoperative chemoradiation. And you are a proponent of high dose 60-day preoperative chemoradiation. So how does this tally? Because I understand that preoperative chemotherapy would have less response rates than preoperative chemoradiation, but higher morbidity and mortality just equalizes the graph. So how do you manage these two contradictions?
Yeah, thank you for asking that very astute question. I think this is where this really becomes a multidisciplinary discussion, and this is something that we have to rely on our surgical expertise. If there is a patient who is likely going to be a pneumonectomy candidate, very straightforward, we would not offer those patients chemoradiation. Those patients will get either neoadjuvant chemotherapy as standard of care, or if there's a neoadjuvant chemoimmunotherapy trial, then patients would be accrued for that, because surgical prior studies with chemoradiation showed high risk of deaths if a pneumonectomy is needed. For patients who are lobectomy candidate, I think this again lands up becoming a little bit of a bias. If there is someone that has multi-station nodal disease, then we suspect these patients would be at higher risk for distant metastatic spread, and maybe those patients are better candidates for induction chemo, as against those that have relatively limited volume nodal disease, where high dose chemoradiation, or if it's a larger lymph node, then high dose chemoradiation would maximize their ability to get a mediastinal nodal clearance so that our surgeons can then proceed with surgery. So that's how we approach this setting. I would say, as a radiation oncologist and with the bias of having chemoradiation, I think the advent of and the ease of doing induction chemo and the ease of doing induction immunotherapy is likely going to drive the field. And unfortunately, I'm suspecting that the use of chemoradiation will continue to decline despite its exciting outcomes, purely because of lack of available expertise to operate in a surgical field, and because of heavy industry push to use window of opportunity trials to get FDA approvals by doing just induction immunotherapy alone to study drugs.
Thank you.
Thank you so much for that really amazing session. I would like to thank our sponsors, Roche, for sponsoring us during the event. And now we will move on to the next session. So we'll just take a couple of minutes break just to set up the items for back again.
It is the future that calls us, our history that forms us. It is a passion that drives us for doing now what patients need next. Together as one, we pursue a better tomorrow. An ever-forward evolution of discoveries across boundaries, among partners, beyond failures, around the world. There are countless reasons why we do what we do every single day. But at the core, it is about our most precious gift: life. Life in all its beauty and its complexity. Life as moments to be experienced, shared and remembered. Life as possibilities beyond the horizon. Life transformed by science, from despair to hope. In 2021, we come together to celebrate where we have been, what we're doing, and where we'll go next. To celebrate 125 years. To celebrate all of us. To celebrate the future. We come together to celebrate life.
We are here together to celebrate life.
I think we need no introduction, and straight away we can start the session. We'll invite panelists. Dr. Jadhav. He was here just a minute.
इसका स्क्रीन यहाँ शेयर करें, पीपीटी यहाँ से छपेगी, मैं जूम यहाँ से कनेक्ट करूँगा, तो ये इसमें लगाता हूँ, लेकिन इसमें है नहीं, इसमें वीजीए पोर्ट है ही नहीं है वाला, तो इसमें कोई भी नहीं है, पता नहीं, मैं इसमें मैंने बोला उसी के
slides also, and by the time we get a slide, then we can have the first part of the discussion. And first part of the, I suppose this is one question which I wanted to ask you after during the branch is also around our hopefully. For chemoradiation, when you decide, for surgery we know we do because we want mediastinal staging and either do the course join up. Or Australia will be willing to go in without mediastinal staging, by and large, isn't it? That's right. Is that correct? Am I saying correct? For lung cancer, you will not go in without mediastinal staging. True or not? You can say yes or no. Mostly will go to mediastinal staging. Mediastinal staging. When do you make exception? You don't. If I small nodes. Otherwise, so PET negative patients will not go. T2, T3 region also. So the node can be visualized. The node not visualized. PET negative. They won't go metastasis.
This one is over this one. I write in a section.
Similar in your place?
So, at our place,
So I had a different person. So
Right, right,
was
right.
different, but other was.
yeah, so for central tumors, for, the things I discussed, but if your question is very specific, you said PET negative,
That negative T3 tumor.
T3 tumor, we would do EVA stable.
So all aspect is not having, that's a different aspect. I'm not saying that. So if you have it. So this was not the question, but okay. So I do agree. There is a not necessarily everyone in India does it. But
So practice is different. Once CCS published now making guidelines, it's basically patient guidelines for long term. I think one of the small ban patient guidelines that you were one of the authors
Yes.
of those guidelines. So as per those guidelines, there are discrete notes, small notes can be accepted. Then proceed
I'm not worried about it. I take the point. I'm not worried about it. And two, I'm perfectly fine. You can remove and you can give something like worried about N3, which you go in and you are surprised, you remove the nodes, you do a bilateral dissection and find that N3 is there. Now,
I agree for large nodes, yes, I'm worried about it. But for small nodes, which are PET negative, small nodes which are PET negative, I'm not worried about it.
not. That's fine. Good.
So,
There is a bit of a difference in the
well, no, because you're asking two different questions. One is, are you worried about N2 disease in a PET negative? You change, so now you
No,
have,
I wasn't. So I didn't specify. I was always worried about N3. So and to have a connotation for the way we practice in PMH, but my always connotation was N3.
so if the question is, am I worried about N3 and what is the amount of worry I should have? I think that one study for contralateral disease in the presence of PET that shows no involvement. There were 0 patients who had N3, 174 patients, but there's no other data. And I will tell you that when there are discrete lymph nodes that are PET negative, but they look abnormal on the CT scan, and we pick those up, there we definitely want to do a contralateral sampling for sure. Now, as I'm
Can I ask you a question? Then when you do PBUS, why you want to do contralateral sampling if there is PET negative? Because it's 100% that you don't find any node other side, and I'll give other data. But having said that, if that's the experience. If my experience is that by T3N0 disease, PET negative, contralateral, I don't get a node, I don't sample.
Yeah, so there is only one study that was published this past year, retrospective analysis. If you're asking what our practice and discussions are, if I'm doing a mediastinal staging, I will always start contralateral. If it is ultrasonographically visible and more than 4 to 5 millimeters, those dimensions are kind of get blurred. But if I'm able to get those, I will sample those for 2 reasons. It takes only 3 minutes. I have high confidence. What I was challenging the notion is what Dr. Shoaib was saying, and if they're worried about N2, right? So they want to have that discussion up front because patient may be a marginal candidate for lobectomy or maybe a risk for pneumonectomy. You want to know that upfront whether they have N2. In that situation, the data is very clear, up to 20% false negative effect, right? And I think there is a devolving concept of how you look at the CT scan. We still follow, I don't know if there's a radiologist, we still follow the old definition of a normal width by short axis diameter, right? So I don't know if that's the best way. There are radiologists who will say this is fatty center. They'll say this is definitely benign. And then there are discrete 4 millimeter lymph nodes that don't belong there. And we don't know if somebody had recent pneumonia infection or they are truly involved with cancer. And that's where they make it.
So we digress a bit. This was not I wanted the discussion to be, but coming back to what I wanted the discussion. So if you in the CT scan and PET, you have a multiple N2 lymph node. You have decided that the surgeons that are not going to operate. Do you here the additional colleges, do you send for medicinal stage?
Definitely, we would like to get it too, but our bet if it is positive, that definitely will be including that in the radiation scale as well. We cannot just ignore the bet inputs that come in.
So, EBUS will get some more nodes which is positive, so you can include more. That's the reason I'm asking.
Exactly.
Do you do it?
Yes.
Do you do it at your side? Go ahead.
So in a country like
Because this is something
India,
which we keep debating in my joint clinic, so that's the reason I'm asking this question. I'll tell you what we do, but
so in a country like India, we have seen people who have had N2 nodes, a lot of them, maybe they're smaller on the CT, but they do have coexisting tuberculosis.
yes.
So we have had a lot of people who had tuberculosis, and then we gave the treatment, the nodes regressed. So I practically would do it in India.
Practically you do it.
Yeah.
Coming back to our relational causality, so if you do it, one is for tuberculosis, second is for having the field. So you do and change the field based on EBUS. Am I right?
Yes.
Yeah. Ashutosh, what do you do?
Can I break your question into two things?
Yeah.
So if Pranshu is going to say,
I know Pranju is around.
yeah, and feel free to chime in, Pranshu, but if the intent is SBRT, 100% of these patients will offer them.
Okay. Yeah, I agree.
So now you're going to advance.
T3 and 2 chemoradiation.
But in this case, we wouldn't be doing an SPR.
Right.
He's putting quite a bit more answering beyond the so that's fine.
I just want to be clear, like I would, if the intent is SBRT and we have PET negative and and radiation is a treatment, that's sort of the pathway the patient is going to follow, then we will offer an EBUS. Now, patient may refuse a procedure or may have other challenges. That is a separate issue. Right? So now you're coming to advanced stage lung cancer where there's a PET positive. That situation, right?
Yes.
So what I hear from Winnie is if the risk for infection coexists, I think to me it is behooving to sample those intestines to make sure one, you're not have two different diseases that you need to treat. Two, for the field purpose, but that's the radiation causes question. Specifically, what is the toxicity?
Does Francis send you all the patient for chemoradiation for EBUS?
Well, he's more of a purist than I am.
That's okay.
So he would definitely want it. I have to actually push back and say, okay, let's.
Why you want?
Yeah, what is one of so I want to understand, not that I want to say no.
Okay. Dr. Pranju, for chemoradiation patient, do you change your field based on EBUS result?
So
Do you
again,
do it to change the so finding out infection is one aspect. Changing your field to for radiotherapy another one. So do you do that and do you do the medicinal stage? Where
so
all
I
this
think
plan is that we will give chemoradiation because surgeon has said I can't go.
right. So I think this lands up being a little bit dependent upon how avid the disease is on a PET. If we have something that's really very bright, 5, 6, 7, 10 plus SUV on a lymph node, then once a biopsy has been obtained for the primary tumor, then there may not be a need for a confirmation with EBUS. I think that at that point we presume and then we move forward. The benefit comes in is if there is a borderline lymph node, which may be slightly enlarged on CT or slightly avid on PET, but not clear, then that becomes a little bit of a judgment call. If we can do an EBUS and knowing that our IP team does very comprehensive sampling, and if it is negative, despite their sampling, then I would be comfortable excluding that borderline lymph node from the treatment fields so that we can keep the fields tight. If on the other hand, the risk to get to that lymph node is high, or if that lymph node is right next to my other lymph node, and anyways I'll be treating it in the treatment field, then there is probably not additive benefit of doing an EBUS to add to everything that has been done. So I think this lands up being a little bit of a subjective decision guided by where the lymph node is located, how bright it is, what size it is, and the context.
So this added. Go ahead.
So we have seen that the tubercular lymph node are more avid compared to them.
So yeah,
You know, the context in 20, 21, 50.
So added question, Dr. Pransul. So we heard we are not so obsessed with investment staging always, but I know if you take NCCN and the practice, the surgeons are so obsessed. You also give local therapy. Why radiation oncologists are not so obsessed with mediastinal staging? 20% you will find extra around if you keep doing it.
I think we land up relying on the clinical judgment of the end of the scenario. There are many things that we are equally obsessed about that our surgeons are not obsessed about. So I think each one of us is looking at certain things with a different degree of obsession, and that's exactly the reason why a multidisciplinary team is needed. So we can constantly keep challenging each other and asking the question as to why do we need to do a particular step.
Ashutosh Madhu, you want to mix?
Yeah, we are all obsessed.
I wanted to know the reason. Go ahead, sir.
Plus, we have the advantage as radiation oncologists to cool down our what we call field size after a basic dose. So we can happily or easily exclude the mediastinal fields, then cool down to stop what is the primary area.
But basically, we don't know the benefit part of it when we get obsessed with that. Go ahead, Dr.
Just a quick comment. I would say that if I know the patient that I'm going to sample and there's a suspicion that this is advanced stage, I always ask him a question. What do you want me to do? Do you want me to do a full staging EBUS? Is it going to change anything? These are the things that I see. And if he says, yeah, that is going to make a change, I will do what their needs are and make sure that those are met.
Coming to our medical oncologist, chemoradiation, which chemotherapy and how many doses and consolidation chemotherapy, yes or no? Immunotherapy, when to start, how long?
So most of the patients who are going to receive the chemo radiation. So I usually go for the paclitaxel and carboplatin, though etoposide platinum is equally good. And when we talk about the adjuvant, and so the 2 more cycles of chemotherapy, that is absolutely, we use the paclitaxel and carboplatin, and we go by the RTOG trial 617. So then we use this also. About the immunotherapy, adjuvant immunotherapy, yes, we offer, though it is kind of out of reach for most of the patients. But we offer it in the patients. I tend to choose my patients based on the PD-L1 testing, since the benefit is most in those patients. And I tend to, at least sort out those patients out of this who have the mutation-based. This is my kind of personal, so that I can make it slightly.
And which one you choose? Which is your work now?
And the time, though in the trial they had taken all those patients within the first 7 weeks, but there has been some data which has even beyond, it is delayed even beyond, though they can also have the same benefit. So I think that should not be a problem.
Sure. Does this Riverbank data puts any bias in your decision making as compared to in the past? So now you have almost 13 to 15% survival benefit, and to disease, we always have been thinking surgery is a better treatment for lung cancer wherever we can put it. Does it assure you, okay, if I'm not, it's okay. This immunotherapy, if we can give it, it's taking care of that aspect of relatively inferior result.
The patient asks me for a patient, most salvage. I have to do the thing. Then I explain to the patient that this surgical salvage option is available. This is the surgical salvage along with the flap to cover the stump of the inside. And this option is given to the patient versus option of the flap. I leave it to the patient to choose. So, most patients in India may not be able to afford it. Okay. So they choose surgery over. The surgery is one time, you get in, so any cost enough to So in terms of Indian scenario, who cannot afford, yes, those who can afford it, yes, they used to avoid, sir. They try to avoid, sir.
Thank you. So maybe so the last question, except one more comment. Dr. Pranshu, radiation job is not going down. You have all targeted therapy, immunotherapy with so many oligo progressions. All we said to radiation oncologically, because we are also worried why to change therapy. So that work is not going to come down. That was on the lighter way.
Yeah, absolutely. I think that we've done that very regularly for patients who are on immunotherapy or even EGFR targeted therapy. If there is one disease site that is progressing, we can treat that very safely with SPRT or relatively lower doses of radiation and improve local control. And that is a pretext of an ongoing NRG study, the LU002, which is trying to assess the role for SBRT and or surgery for oligometastatic sites in the setting of chemoimmunotherapy for non-EGFR targeted therapy. And there is very likely survival benefit that will come from those approaches.
Thank you.
Go ahead. Do you ever send your patients after immunotherapy, sir?
Yes, and always. And that's why my browser against my surgical colleague, they don't operate. After targeted therapy and immunotherapy, both types, and then if you have a oligo progression to remove it. I've been able to convince my radiation oncology colleague. I've never been able to convince my surgical oncology colleague, and I have always make a point to tease them in my joint clinic care. We keep sending you, not me, it's like PMH, I'm one of the persons who works. So we keep sending patients after oligo progression, but not one. We have been able to convince them. See, it's not easy. What has happened is, we need to understand that we are saying T3 N2 disease, multistation, we don't want to operate. T4 remunerative, we don't want to operate. Now, having the concept that you have an M1 disease and want to operate, it takes time. And I understand that mindset. It's not easy. It takes some time to convince, and hopefully it becomes routine, then it will be routine. So at this moment, that's a challenge, because what we have seen with N2 disease. Why Sweat sends N2 disease for chemotherapy? Not because you can't operate. Most of the N3, why not? N3 can be operated. It's not a big deal. The median survival is in months. There's a challenge, and the people don't want to do tracheotomy and doing lobectomy and pneumonectomy with having a median survival in months. So that concept of choosing those patient oligometastatic disease at this moment, so I'm not able to tell you.
So, Kate,
Go ahead.
could you help me understand a little bit on when you said oligometastatic progression? Are you talking about local, regional lymph node, or are you talking about an isolated site?
Anyway, so obviously my surgical colleague, usually they won't, like bone and other places not, they will never be able to venture at this moment. I can't say in future. But anyway, so like for example, if I get soft tissue mets separately in my PET or a scan, I do send all those patients. So all the patients on immunotherapy or targeted therapy, they will move to both places, radiotherapy and medical oncology support. So they will be seeing both the places. So anytime you have this, they will go for the reference. The view may not clear. But yes, it can be anywhere. It can be in the lung, or it can be.
So your question, so pardon me if I was. So your question is to remove the primary site that was previously treated.
No, actually, if you can remove, great. If you can't, at least remove the because that's the insensitive one. Like we do in germ cell tumor. So we give them example. You give cisplatinum. Cisplatinum has not worked in some place. We don't have any other good drug. If you remove it, all other places it is working. So we say other places is working, that tablet or whatever we have given. If you have one or two places it's not working, so I'm sure Pranshu will be giving SPRT. So here also we are able to if you have a good dose, and then you do get good months without any systemic therapy. But same concept is go ahead and remove those lesions because they are insensitive ones. That's the concept.
And I think if I might add, the other benefit of surgically removing some of those oligoprogressive sites is also from a research perspective. We know there is heterogeneity in oncological population in the tumor cells between different areas. And if there is a localized mutation that's developing in a area, that could guide further use of systemic therapy. Point one. And point two, Dr. Prabhash, I'm sure you would highlight that more, that conventionally data has also shown that in patients, especially getting EGFR targeted therapy, stopping the drug can cause pretty rapid withdrawal progression. And that's another reason why if through surgery or SBRT, we can take care of that oligoprogressive site, it allows you to continue systemic therapy with targeted agents or IO much longer.
Totally. So with this, thank you. We close the session and thank the panelists.
And now,
This one, correct. This one?
Tumor, if we cloud them, then in our population, they are all very managed bit differently than human disease. Or maybe another way say stage 1 and 2, then even N1, then
Stage 3A onwards, it's non-metastatic. Yeah, so this is generally what we feel that stage 3A onwards. Please, next one. So I will not bore you with this. Again, I'm stating next, please, next. So this one. So stage 3A onwards would be locally advanced. And some would also include B3 and 0 when in specific circumstances. For example, like pancreas tumor, supercilious tumor, just one area. So these things may be included as a locally advanced tumor. Next, please. Next. Okay. So let us come to a 64-year-old lady with a problems of 2 flights. Had cough in the next year for 6 months. And performance status 1, BFC of 60%. Next please. And that's the CT scan, average CT. So there is a 3 centimeter lesion in the right lower lobe, and you update in the triangle without any distant metastasis. The MRI of the brain is done, which is normal, and the biopsy is adenocarcinoma. Next. So what next? It is a P2 disease with a single station N2 which is resected. So these are the options: upfront surgery with systematic mediastinal lymph node dissection, invasive mediastinal staging, neoadjuvant chemotherapy followed by surgery or definitive chemoradiation. So, Shweta, please.
I would like to state the disease with us, and the mediastinal node is positive. I would prefer to give the patient neoadjuvant chemotherapy. So, followed by surgery.
I hope that should be a consensus among everybody, or is there a different opinion here?
So Raj can comment about his tri-modality experience. So that would be concurrent chemoradiation.
Yeah, so we begin with mediastinal staging and then go for a neoadjuvant kind of therapy, right? So next please. So EVAS was done and the subcranial node is positive. This patient received 4 cycles of neoadjuvant chemotherapy with and one can ask a comment on the neoadjuvant chemoradiation as well. Our bias has been for chemotherapy neoadjuvant rather than chemoradiation, but I completely agree that chemoradiation is a good option in such patients. Neoadjuvant chemoradiation. And do you follow neoadjuvant chemoradiation?
No, we don't. I can see it can be, but no.
Yes, sure.
My concern is in the light of the recent paper, 2020 paper, after which the post of RT is now being awarded. So, when for a single node, when they can award post of radiation mediastina for cardiac concerns, then why should we irradiate mediastina when we can remove the disease surgically?
So wherever we have, in whichever site, we have had these kind of debates about post-operative or pre-operative radiation. We have seen that, let's say, gastric cancer. So there was a discussion on D2 dissection followed by radiotherapy. And the better your surgical dissection is, the lower the value of post-operative radiotherapy. So that has been the general feeling among most of us. But I agree that neoadjuvant chemoradiation is an equally good. So this was followed. Yes, please.
So I want to ask, sir, how many cycles do you use in neoadjuvant?
So we usually use 3, but 3 to 4 is okay. Some people have used 2 followed by 2. I don't know, so that is a.
That was my first question. If in case we use 2, then after surgery
you give 2.
So better to give 2. Not necessarily everyone has done it. I need to, in fact, the trial which was shown by Dipanjan, not necessarily they have always used it. So that variation is there. So here you take a bit of a logic rather than you get a hard data to it. By and large, in adjuvant, we know 3 to 4 is good. And same what you're saying that give later or give early, it is similar. And that's why we take 3 to 4. So we give 3, but again, if someone gives 4, I will be considering that it's fair.
So right now, lobectomy was done. It's systematic.
Only that's it. But I say be careful about in N2 disease or chemotherapy. That 5% is total. The moment you have N2 disease, this benefit is in double digits. So it is 15% around. So be careful. If you don't give it, it's a problem. When you give, is not a problem. If you don't give it, it's a problem. It's not T2 or T3 N0 disease where you have a 5% benefit to the patient.
So histopathology was 3.1 centimeter adenocarcinoma or marble lymph node 1 out of 18 in the subcranial station. Next, please. So, any role for further chemotherapy post cycles have already been given?
We don't.
I don't think there will be a lot of further chemotherapy.
The pathologist can come in. Any molecular marker study to be done at this stage? Or maybe Dr. Vikas, is he there? Vikas, no. So, at this stage, any role for molecular markers?
At this stage,
I think I both.
there could be a role for this mutation analysis. If a trial comes tomorrow saying that adjuvant mutation follows them with TKI.
So you want to collect the samples for future analysis, not for this particular patient.
Yes.
Is there a role for this particular patient?
I know there is a trial.
So, two things here. So this is a endo disease. There is a role for testing, that is EGFR testing. If it is positive, there is a data for osimertinib for controlling the disease. Controlling the disease data is that if you give it and if you don't give it, the difference is around 40 to 45%. And now that kind of data we have not seen. OS data is pending, but disease control of this magnitude has a fair amount of merit to be considered. So yes, that option should be discussed with the patient.
In an adjuvant setting.
Absolutely.
So what do we define? How to define the disease control in the adjuvant setting?
But it's a disease survival. So because 40% versus 80%. Now when you have data like this, 40% versus 80% disease-free survival in the two groups, that's something one needs to consider is useful. Now, second part is PD-L1 testing, which data came relatively recently. That is for atezolizumab. And again, in the PD-L1 positive patients, in case it is EGFR negative, then what we do? EGFR positive, so we know it. Other biomarkers we don't have data. Then PD-L1, in case EGFR is negative, then PD-L1 data, if it's positive, then the disease-free survival again median doubles. So again, that becomes meaningful. Both are costly drugs, both obviously costly, but yes, as an option in today's time, yes, this needs to be. Go ahead.
Yes, I think before the lack of time I didn't show. So because of this trial, Adura, this now osimertinib is tried in a neoadjuvant trial. It's called neoadjuvant. And another thing, in this neoadjuvant single agent atezolizumab study, they show the cells which are actually EGFR mutant, they don't respond pretty well to. In fact, they have a very poor response to neoadjuvant IO. So that's how the concept of now neoadjuvant targeted therapy is coming. So most probably doing these all markers upfront before starting neoadjuvant therapy will become a standard of care in coming time. So you decide whether you give chemo or you give chemo immuno or give targeted therapy or give chemo with
this moment, if I go back to my first slide, which you please don't go back. The biopsy was adenocarcinoma, we knew that it is an adenocarcinoma. So, would anybody consider neoadjuvant TKI?
No.
Not as an adjuvant, you may consider provided the patient has the resources for that.
That's we need to give options to the patient. Yes. Right. The options should be given to the patient.
I have a comment on this. So Kumar showed that combination of genetic and chemotherapy calculating in the metastatic setting was associated with a very good progression to survival in the guidelines. So why not in the neoadjuvant setting when there was
data has to come. That data has to come. We have learned from colorectal liver metastasis that what was effective in an adjuvant setting was actually detrimental in the neoadjuvant setting. So those things are nuances which come when only on the data.
responsibility for the
Yes. Next.
patients who are older, those who cannot tolerate chemotherapy, they are being to take
All right, any role for post-operative radiotherapy? We wind up this case. Any role for post-operative radiotherapy in this setting? Srinivas.
Yeah, hi. So most of the post-operative radiotherapy data is after upfront surgery. Having said that, I would not prefer giving post-operative radiotherapy in a completely resected lung cancer. So because this is margins are negative, despite it being an N2 disease, this is not N2, this is post-induction chemo
Yes.
N2.
Yes.
And despite that, I wouldn't. I mean, there is there is tons of data that post-operative radiotherapy should be very carefully considered. So I definitely wouldn't give in this particular situation with single node into all margins negative.
Sure.
May I provide an alternate perspective to that too? Because again, this is exactly an area of controversy. So I think, first of all, the fact that this patient had residual N2 disease after induction chemotherapy, at that point itself, one could question the role for surgery, because mediastinal nodal clearance, even in induction chemo trials, have been shown to be very important. And if there is residual disease after induction chemo, most likely that patient's biology is less responsive, and the outcomes are unfortunately not going to be as good. And maybe surgery is something that may not have been needed. As the first point. So those patients could then have been transitioned to chemoradiation and then go on to get durvalumab or some immunotherapy, even though it's not classic specific paradigm. But on the second front, again, the reason that that I would suggest this is probably the patient population that might benefit from port to the mediastinum is because the response to chemotherapy was poor. There's no other, in non-targeted therapy setting, there is no other option available. And we know from the port studies that mediastinal relapse rates were reduced with the addition of radiation. The studies that are currently looking at induction immuno and induction immuno chemotherapy in Alliance and NRG or in Europe as well, if a patient has path CR, then port can be avoided. But if there is residual N2 disease, even after induction, then there may be benefit of port. So that's how I would like to see it.
I would think that post-operative radiotherapy will have less concerns. Then probably an alternative to surgery. For example, if you do a restaging, remediational staging after a neoadjuvant chemotherapy, and then if you pick up a mediastinal lymph node again, re-EBUS or remediational story, and then send those patients for chemoradiation rather than
with two evidences. One is NCCN, then one is private. Number two, there was a paper published in Cancer, the Japanese study, where they studied patients who were treated with chemotherapy as well as chemoradiation. They found that the response rates obviously were more to chemoradiation. But irrespective of that, patients who were downstage, whether or not they received chemotherapy or chemoradiation, the downstage population showed difference in OS. Their OS was better compared to population who could not be downstage. So this patient who is downstage could be downstage. So I think there is a valid point.
So that both points exist. Next, please.
Can I make a point, please?
We are running short of time, and then we have to cover other cases also. So this trial, everybody knows, addition of surgery in stage 3 lung cancer is next. So exploratory analysis or overall survival was improved for patients who underwent lobectomy after neoadjuvant chemoradiation. Patients who underwent pneumonectomy had a worse survival. So that's true. Next, please. Next. This one was a very interesting paper from the Memorial Sloan Kettering, where a combination of radiotherapy and right pneumonectomy had a mortality of 23%, post-operative mortality of 23%. And left pneumonectomy had a post-operative mortality of I think 4 or 5%, and the combined mortality after pneumonectomy was around 11 or 12%. So right pneumonectomy plus radiotherapy in whichever combination, whether pre-operative, post-operative, is a very fatal situation. So should not be used. The left side, generally the stump retracts into the aortic arch, so probably it's a more effective. But 75% patient death also. Yeah, but post-operative mortality, it's a 24%. Advantage of the patient cannot afford to do that. What will be the outcome of that patient who will be left with no option? That when we make a decision to operate or not operate, send the patient for aggressive chemoradiation, the benefit is not that huge. So we have seen in that paper that the patients who underwent pneumonectomy did worse. No, after that there were some reports published in 2004 where the series are not very huge. 10 cases, 29 cases. All right, so we move around, and next one, please.
inversion and left-sided chest pain. No supraclavicular nodes, good performance status, and FEV1 was 68%. Next. And there is a 7 centimeter mass in the upper lobe invading the chest wall. No significant tumors. Non-small cell lung cancer, there were squamous cell carcinoma. MRI brain, normal cell. Now what next? Next please. Now upfront surgery, neoadjuvant followed by surgery, definitive chemoradiation. Let us not go into the debate of mediastinal staging at this moment. So suppose it is a T3 and 7 centimeter, now it is T4, 7 centimeter plus. So with that information, 7 centimeter T4, N0, but eminently resectable chest wall, what do we do?
T4 tumors which do not metastasize to lymph nodes are biologically good tumors. We must operate on them. Yes, I agree that we should do a mediastinal staging. Even a lesion which is involved in chest wall, it cannot be reduced to the so I think we should do chest wall resection.
Any role for neoadjuvant because not is T4. Previously, we used to think it is T3, we used to operate.
Correct. So I think so. That staging has changed because of prognosis, not because of treatment. Treatment decision remains. So I think so. For me, the staging which changes really doesn't help me in my decision making. It's more just gives me till now at least for some time. More information for decision making is not come. So for me, if you can remove it, I have no doubt. Go ahead and remove it.
Next. So this patient underwent a left upper lobectomy with chest wall resection, third to fifth dip, with systematic mediastinal lymph node resection. Now, Dr. Darmo, what would be the method of the reconstruction after chest wall resection?
Yes. See, Durgatosh, I mean, mesh is good enough, but third to fifth rib, I mean, in that case, we tend to use our own technique of using the wire, the steel wire, basically. We just bridge in between the defective ribs here, and then just put a mesh over it. I mean, it works very well.
So we have seen the people using mesh plus cement. Now, Dr. Darmo is talking about wires. Some people are with bone cement creating ribs, making the shape of a rib and attaching one to another. So 3 ribs have been removed, they make 3 ribs out of the bone cement and do this. These are interesting procedures, time-taking, but time-taking. And the mesh also works quite well. In the post-operative period, there might be some respiratory issues, and that is visible. The paradoxical movement is visible. Patients are not generally in that much distress. In general, what is your experience there?
No, I agree that the mesh is the simplest thing which can be done, and it can be covered with a maintenance flap. What I have observed in patients who are doing chest wall resection, they do develop flared chest. Yes. And what I have seen that what we do normally in our center, we electrically ventilate them for at least 24 hours. Okay. And after that, we have not found because we had instances where we had to reintegrate those patients for electric ventilation, and then they develop vicious cycle of pneumonia and other things. So it's always better to ventilate them at least 24 to 48 hours. Then
the exception to reconstruction is sometimes the posterior, which is covered by the scapula. So that area of the chest wall which has been removed and can be covered easily by the scapula, that part some people will not, but most of us would still put a mesh. Okay. So chest wall invasion, the 5-year overall survival is 50 to 60%, but arterial resection must be ensured. Next week. So histopathology was squamous cell carcinoma 7 centimeters invading the pleura and in hospital. The rib was not involved. All margins were negative, lymph node negative. So PP3N0, Y is the wrong time. So any adjuvant chemotherapy obviously that needs to be given. Any role for post-operative radiotherapy? Dr. Pransh.
In this case, I would not offer post-op radiation. Hopefully, Dr. Srinivas would agree on that too.
Okay. Next, please. So this is the third case. A 54-year-old man, a chronic smoker, pain in the left upper chest and cough. Performance status good, no supraclavicular nodes. So here is the CT scan and the PET CT. There is a superior sulcus tumor in the left side involved in the first one. It is abutting the subclavian artery. There are no significant nodes. Biopsy is squamous cell carcinoma. The MRI brain alone. Next, please. So, any role of for MRI? MRI of the chest and chest.
We normally do it for the test of tissue.
So it will assess the subclavian vessel.
We normally do MRI
For the vascular as well as the assessment these things. Dr. Darwin, you will do for all your cases.
Yeah, I think MRI is not very much necessary. I would like to get a multi-slice CT with contrast. To see the vessels basically.
So, what is the plan now, Dr. Srinivas? What would be your plan for this patient?
In my center, most patients of such kind of disease with very close proximity to vascular structures, unless the surgeon is very comfortable operating, we would offer them definitive chemoradiation. Sorry?
Definitive chemoradiation.
Yes.
Okay. Any differences in opinion?
We normally treat them in neoadjuvant chemoradiation up to 45 days, then do surgical operations. Yes, if you can resect, no doubt that neoadjuvant chemoradiation and resection. I do agree that if resectable also is good to give neoadjuvant chemoradiation. Resecting upfront is not the best way to go about it. But yes, if resectable, resection should be part of it.
So next case, next one. So chemoradiation to 54 gray was given in this patient. With concurrent Capnicato and chemo continued for 4 cycles after completion of the radiation. And this was followed by left upper lobectomy with mediastinal lymph dissection with the resection of the first and second ribs. And the approach of surgery, Dr. Darman, what would be your approach of study for the surgery for superior cervical tumors?
See, I would approach in both from the anterior aspect as well as the posterior. It will be a long thoracotomy. That's basically going way beyond in the interscapular. So that you are basically, bang on the first rib from the lateral aspect, and you can basically dissect off your subclavian vessels and all that.
So there will be 2 incisions for you. One is a posterolateral thoracotomy, other than anterior.
Yeah, it will be going way beyond posteriorly interscapular.
Dr. Zeddy,
Your approach for anteriorly placed bankos, I would prefer to give incision, which will be basically a shape incision, which will start in the neck and go down, and then it can be extended to the second rib or third rib.
So in this particular patient, and that has been my policy, that we start with a cervicothoracic incision, a shaped incision. In case we find it difficult to approach the hilum later while doing our lung resection, then it is then that we move the patient and we would consider, but most of the times in a couple of excision,
Prefer to do thoracic dissection for the hilum, followed by dissection.
In this particular patient, it was manageable by just L-shaped cervicothoracic incision. It involved removal of clavicle, first and the second ribs, and extension on the lateral side and the lateral leg. The histopathology shows a scanty residual squamous cell carcinoma with polygated nodes. Any further treatment, 4 cycles of chemotherapy has been given, there is 54. Suppose that you can just maybe that's
we were talking about. So I think that should be considered everywhere. Planning for surgery. These were not the patients which were taken in that study, not the chemoradiation patient. Neoadjuvant were taken in that study. But having said that, I don't think so there's any other reason why it should be working in this situation when your surgery as a part of the.
Next please. So next case, it's a 35-year-old man, never smoker, first order school, dry cough and weight loss, no supraclavicular growth. Next please. And this is the PET CT. It's a multi-station N2 disease, biopsy, adenocarcinoma, MRI, brain is low. What is your strategy now?
Dr. Srinivas. Dr. Pranshu, you can take this question.
Yeah, so I think for this patient with multi-station N2 disease, we would most likely consider definitive chemoradiation therapy.
What do you mean by multi-station? Nowadays, they propose that if it is a multi-station involving a single zone, then the neoadjuvant chemotherapy followed by surgery will produce further.
So here, the level 4 on the left side and 5 and 6 are recorded.
Level 4 on the left side.
And subaortic cardiopulmonary are recorded.
The two zones.
Yes.
Then I can go to the chemoradiation.
Okay. So next day. So the treatment is definitive chemoradiation was given 64 grade 32 fraction. Chemo continued for 6 cycles here. And after how long would you assess for the response? And how would you assess for the response? CT or PET?
Usually around after 2 and usually by PET CT. But I do agree that it can be a bit variable both technology and the timing. What you're doing, you do get so many changes that it's tough to evaluate. So usually we do it after 3 months and PETs.
Next week. Okay, so this was the PET CT done after 3 months. There is a good response at most and partial response at the time. With some lung changes post radiation. So next.
So the patient is actually a non-smoker. So there's a high likelihood and it's an adenocarcinoma. So high likelihood it may be EGFR mutation positive. So you should do a EGFR study and first of all adjuvant oxygenation.
Would you biopsy?
Biopsy at the end of 3 months if they're that positivity. You can wait for 3 months post radiation. That's good identification that case.
So that's it. Not now, because there's no new lesion, and that was a new lesion, and we discussed with my radiologist that how comfortable it is because of RTO is really not new. But upfront tissue, yes, I will be doing. So that's the reason when you're planning the patient for chemoradiation, one of the issue aspects we should remember that you can be in a situation where the disease comes back, you don't get tissue. So those tissue at the baseline is important, and have a worker testing done. It may be useful for your decision making. So that is where it is important. Here, residual disease biopsy, no, unless you're planning for surgery. In case you say, I can undergo for surgery, then yes. But by and large, when you are giving chemoradiation definitive, very few patients, which is one for surgery subsequently, pretty rare. Usually we don't do it because the other aspect is that you don't know when you do after radiotherapy and chemoradiation, representative or not, atypical sense, seeing the so there's a vicious cycle which starts subsequently.
So here, would you prefer to give durvalumab here at this moment, or you wait?
No, I would have given it. So durvalumab has evaluation has got no direct correlation with starting durvalumab. So after the chemoradiation is completed, start as early as possible. See that patient doesn't have a pneumonitis, which can be troubling to the patient. If that is not their patient is not symptomatic, go ahead and start durvalumab. Don't wait for your reevaluation.
Is there an option right now?
So that is a question which has been answered by only one. There's some trials there. One trial which was a good one, where the chemotherapy was not the main one, but it showed that conservation chemotherapy given help. So by and large, people will give chemoradiation. It's not conservation chemotherapy, except with a caveat. If you're using paclitaxel carboplatin, you're not using systemic dose. So you're using paclitaxel, that is 50 milligram per meter square. If you're using 2% platinum, which is systemic therapy dose, then for sure I don't use conservation chemotherapy. If I'm giving paclitaxel carboplatin, then yes, I may consider that.
There is really role for any salvage surgery in this particular situation. Can we go back? It was probably left lower lobe. Laparoscopy was
then I think we have a we can dual.
The next, please don't move the slides.
I just want to ask a question to sir. Sir, would you not like to consider for imaging before starting the Valuva?
It was not done. I understand your point.
I think they did CDR 2 weeks post CDRT.
If I remember, no. In that study, maybe I'm wrong. I'll check it again. I think that's one of the criticisms for the trial is that could be when we're treating many of those progressive disease which are metastatic, and that's where the benefit is there. So that's a criticism. So the criticism for trial will be there. This is what I remember, but I do concede could be.
Patient technically suitable for allopaty, but we discussed with the patient topics of oxygen on post just patient agrees that when do you say that I will not do something? No patients. I am not pushing yes, if the patient has to also immediately, then also not pushing. There is a lot of radiation fibrosis causing discussion of this. There's a lot of fibrosis, frozen, iron, and then they so most of the surgeons would be a little reluctant in going for the salvage therapy after definitive chemoradiation. Yeah.
So I'll say, see, what if your patient was inoperable after? So this was not unnecessary. So I do consider it's not unnecessary. I know that this, there were multiple smart surgeons who can go in and remove it, but it was inoperable upfront. If it is inoperable upfront, what I will suggest, be very careful.
Just as we are careful on the progressions, we are also careful on those.
And second, once in a while we have done it. I do agree. You said, Kumar, have you and your team have you never done it? No, we did it around just 3 months back. We have done a patient where we had a respiratory disease and eminently resectable. But with a catch was that patient was not affordable for development. That is another aspect we should remember. I do agree if you have residual disease. I do understand your concern that the residual disease is there. You don't have anything there. This is a tough situation for patients. We are looking for palliative setting.
When the mediation has been stabilized, I agree on when the mediation has been stabilized, the data with the chemoradiation, spirometry, biotherapy was there could not be any OS advantage for patients for the surgery. That was because of the high mortality of patients for developing.
So one of the gaps also was these patients were not included in those trials. These were the patients which were so we have also I'm not saying but these are patients where the data group 0, 1, 3, 9 trial. Yes, their mortality
and the dose of radiation was much less.
Not only much lesser, you have multi-patient, more positive patients. I'll give you one data. So again, this is everyone to mull over, and I can sure one can debate that impact was not there. 2 randomized trial what is shown for any gene for N2 disease. What was the median survival in surgery now?
Only surgery.
Only surgery. It was 8 months.
8 months. One was 31, or was it 8?
So sorry, that doesn't mean anyway. I'm trying to say I have made my statement clear. I think surgery is one of the most important modality where you can resect it. When your nodes are locked, it suddenly things changes a lot in your the way the median survival of patient happens. That we need to remember.
But that trial, what the number of patients was less. I think that was 60 patients.
So the problem what you forgot to add is I totally agree because trial was stopped in internals.
Yes.
You know what was the survival? 8 months versus 26 months. The curve in the surgery arm dips, it reaches to the down.
Absolutely.
No patient surviving. No, we have not seen why it happened because PET was not there at that time. Medicinal staging was not so good. So a lot of patients included with very high volume disease. And that's the reason we had stopped the trial.
Exactly.
I'm not saying don't operate, but
generally speaking, we would be reluctant in operating on these patients.
Like the Japanese patients who had
their OS was significantly better. It was around 15 or 40% compared to 40 hours per versus 10 hours. So the mediation was still there. Then I may not go for surgery immediately. Maybe a patient requires something. The patient remains disease-free for significant work, and you should consider surgery.
So I just want to make so in the radiation talk, we had a high dose neoadjuvant chemo radiation. So that radiation dose was 60 days. 60 or 64, I don't know how different it is, but considering that then that patient could be a candidate for the stage trial at 60 days. So this is the problem. This is the cost with that we use for surgery.
Basically, definitive chemo radiation followed by
I don't remember, I may be wrong, but I don't remember any trial of Transhu.
So the data that we presented is part of our institutional experience. And again, the idea there is patients get definitive doses just because there is uncertainty whether they'll end up going to surgery or not. And stopping at 45 gray is suboptimal. So the goal is to do full course, and then we assess patients at about a month out. If at that point, the disease shows a good response and the mediastinal nodes have cleared, then select patients can undergo surgery. But if not, then they all receive durvalumab. And so to Dr. Prabhasha's point, I think in this case, we would not have waited 3 months to do a PET scan. We would have assessed a scan at 4 weeks, assess mediastinal disease, and if there is any residual, but at least a positive response, then patient gets durvalumab right away.
Philosophically, this is what Jackie was saying, that if there is a mediastinal clearance, then surgery may be a good option. But no,
that's not we do not follow. I think the point of view, and I respect that. But take home message is exceptions. Rule is that the moment you decided inoperable disease, chemo radiation, and so these are exceptions. We all make exceptions. I have given chemo to pharmaceutical 3 patients. But what I tell my students, I'll be saying, hey, this is an exception. You should know it is an exception. We don't do it, routinely. That's what I was convinced. That doesn't mean I'm saying I have not done more. We have done it. I do concede.
Okay, now go ahead with the next one. We agree to disagree. Next one, please. So this is a 56-year-old man, an ex-smoker, cough and hemoptysis for 3 months. PS1, no supraclavicular growth, and excellent PFP of even of 92%. Next, please. Very fit individual. Bronchoscopy suggests an ulcerated lesion in the right main bronchus, which is just about 2-3 millimeters from the PET CT shows a mass in the right upper lobe bronchus with the legislation to right with the lobe. No significant results, no metastatic disease, even no mediastinal lymph node biopsy, squamous cell carcinoma. So it's a squamous cell carcinoma in the iron without total lymph. Next, please. So this is how the picture is. On the CT scan, I do not have the picture of the PET here. And this is somewhat graphical representation of how the bronchoscopy looks like. It's about 2 to 3 millimeters from the carina with some edema which is extending to the PET. So in this setting, what would be the plan? Next, please. So what is the plan? Definitive chemoradiation, addition of brachy. I think Dr. Pranshu can take this question now.
So the brachytherapy question, I think, is a relatively easy to address. Because this has clear mass that's fairly thick, we would not be able to adequately treat it with brachytherapy alone. If, on the other hand, this was just an endoluminal process, then maybe as an adjunct to cryoablation or such interventional approaches, brachytherapy could have been added. But based on the scan that you showed, this would be too thick.
In addition to definitive chemoradiation.
Again, I think after definitive chemoradiation, we would most likely offer this patient consolidation immunotherapy, because brachytherapy for one-sided disease like the scan that you showed, it's extremely challenging to deliver, especially at the level of the main or the right mainstem bronchus, or even in the right intermediate bronchus. The diameter of the airway is such that it's very difficult to get the brachytherapy catheter aligned in an appropriate position. Now, there are some efforts being done to try and use multiluminal catheters to potentially allow that approach, but that's not as easily available.
Dr. Garu, any role for neoadjuvant chemotherapy followed by surgery?
I mean, I think I would not really think about operating on this. I mean, I would not really consider for surgery.
So this is a little controversial. Yeah. So next slide, please. So we showed the bronchoscopy. So we treated this patient. This was a very fit individual, a 40-something old fit individual who was motivated for a surgical approach, and we gave neoadjuvant chemotherapy with cisplatin and immunoglobulin, and right pneumonectomy with partial cranial resection was done. The picture that I graphically showed was the picture at the time of surgery. I think the medial was right bronchus can be correct. So that is what was done. So the infant feeding tube that we see there is looping the left main bronchus. The carina has been a part of the carina has been removed, and then a transverse closure has been done using some flap of the medial wall as the is seen. So a cranoplasty, right pneumonectomy with a partial cranial resection and cranoplasty was done here. And next, please. So the histopathology shows a 5 cm residual viable tumor, squamous carcinoma involving parietal tumor, frontal margin 3 mm, but it's green. Lymph nodes are 0. A few nodes shows granuloma with scanty epithelioid cells. Any role? I mean, I don't think Dr. Pranchu, would you like to add radiotherapy to the post-right pneumonectomy patient?
So most likely not. Again, post-operative radiation therapy in pneumonectomy patients is also considered high risk. And so in this session, in this scenario where the margins are clear and the nodes are also negative, we would probably not. The only area where I would get surgical input is the area where there was involvement of parietal pleura was an appropriate margin taken. That can sometimes be a scenario where the disease is close and a chest wall resection is not feasible, and then we would consider directed radiation just to the chest wall margin. I don't know if Dr. Darlong, if you feel differently in those settings where disease extends to the parietal pleura.
Any role for anti-tubercular treatment with this? We often see granulomas in the lymph nodes and some epithelioid cells. Generally, we do not give anti-tubercular treatment here, but why I mentioned it here is next slide. So 18 months after the surgery, the patient had bilateral pleural effusion, and cytology was negative, and this time the pleural fluid was healing with AFP. We discussed the option with everybody at that point of time with the histopathology report of granuloma with epithelioid cells, but we made a conscious decision not to give anti-tubercular treatment. But he was started on AKT after 18 months, and he succumbed to toxicity. So if we do not know what kind of granulomas are actually tuberculosis, I think Ashu can add on that.
Well, I think I'm limited with not practicing in India, but we commonly see granulomas with epithelioid cells in patients
with any nodes of cancer.
In patients with breast cancer,
yes, all.
Yeah, all types.
So, yeah. So when do we? I mean, this was we burnt our fingers here. So
I don't know if you burnt your fingers because once the patient died of hepatotoxicity of a treatment you have given out, right, with no evidence that he had TB. I think if there was a concern, so I'm thinking the case was that ulceration tumor or was that ulceration at the TB that was
Durgatosh.
Yes.
Yeah, we also had cases like this. I mean, the lymph nodes show some granulomas, epithelioid cells. So most of the time we avoid giving anti-tubercular, I mean, when the AB is negative. But usually on the follow-up PET scan, they do tend to have sometimes some lymph nodes coming up on the PET scan. And those we again do an EBUS, and the gene expert usually comes positive by that time.
So the pathologist needs to do more forthcoming. So in this case, getting diagnosis or next to AFP. So all you get to enter context on that.
Okay, so if those things were there, you would have certainly contributed with
sometimes the pathologists don't comment on the case.
We discussed that issue because this was very important. We had performed a controversial surgery. Right pneumonectomy with a partial granuloplasty and supposedly near T4 tumor. It's a very controversial surgery. So So we wanted to be very sure that it works.
So it's very unfortunate that the patient survived the cancer and died due to a very simple negligence that is not monitoring vital toxicity when we start activity. So that's the key message. We should always concentrate on the basics.
Yeah, I don't think, you don't know. It could be idiosyncratic reaction of the drug use. Whether there was a patient factor, the patient couldn't get to monitor, or, we shouldn't just do a profile without that information.
I know a patient who operated on some days. 2.5 years later, she had some fluid, which was and then there was some query about tuberculosis. But finally, some chest physician started tuberculosis. She was not a doctor, and then after taking ATT, I think she took it for 15 days, and suddenly the patient's son got a call that she had hemolysis. And then he rushed to. I went with him. She stayed in Rohini, and then she was taken to Rajgiri classes too. And I went with them. We did not know what happened to her, whether it was a toxicity of the drug or because we she succumbed to it.
Actually, for weekly monitoring for the first month is recommended for the liver functions, but nobody does it. So that's the thing. When you want to stick to.
So next, people want us to have this.
It's very common. It's not an uncommon. Possible. It's quite possible. I don't know. I don't know. It's just mulling on that. We always think about those things which we are confident. Next one. What's the last one? So next one. So last one, a 68-year-old man incidentally detected mass leakage of treatment in left side chest, opinion of 64%. Next one. 4-centimeter mass in the peripheral region of the right upper lobe lung, no significant loss, non-small cell lung cancer, MRI, really was not in this question. Next one. So upfront surgery, SBRT, mediastinal staging, 4-centimeter mass, and zero disease on vaccine. Mediastinal staging, yes. Okay. Next one, please. So this is a very provocative thing. That's the reason why I got it up. We did the surgery because we were at that point of time not doing mediastinal or mediastinal staging for PET CT, which does not show anything from the mediastinal. So the histopathology was 3.8 centimeter adenoid squamous carcinoma, the way margins free. The lymph nodes 2 out of 22, including one lymph node which is in station 4R, which is the N2 station. Obviously, adjuvant chemotherapy will be given. Next one, please. So, was it a mistake to operate upfront? Is the oncological result compromised because of our upfront surgery? I don't think so.
Single station node, the survival. I think it was quite negative. It was quite negative. Then single station node, which is operated upfront, because that is the Indian practice in Europe and Britain. The British Society guidelines, I could not show my presentation. I have a slide, I would like to show it, it's not wrong in that. British Society guidelines, nice guidelines, they recommend upfront surgery for a single station. They, one of the papers based on those guidelines, I think it was the British Society, they said patients with multiple and non-lymph nodes compared to a patient with single and two node, that survival was worse versus multiple and non-lymph nodes.
So I would say this: we come across this situation otherwise also. Let's see if you have done mediastinal and then this surgery and then it happens. This is one. But one case doesn't decide right or wrong. But I'll give you some number in 100 patients. What happens? So where we have a concern, why you are asking this question because routinely most likely you are sending a patient for chemotherapy. Now why do you send it? If we were all convinced that similar, you wouldn't be sending. But you also are not sending for N1 disease. Then why did you send for N2 disease? Data is there. NASH trial was shown. It is similar. Adjuvant or new adjuvant. Remember, it was not for N2 disease. There is a meta-analysis. Looks like hazard ratio is similar if you give new adjuvant or adjuvant disease. The problem is that are you going to deliver? So if you give an adjuvant setting, you will be able to deliver adjuvant chemotherapy in 60% patients. But if you give a new adjuvant setting, you are able to deliver the chemotherapy in 94% setting, 94% of the patient. Now, someone can ask a question, do you have data that if you deliver this way, then outcome is different? No, we don't have data, but this data is enough that we have 3 surgeons, and I know that all of you sent for N2 disease for new adjuvant chemotherapy. So this patient is not wrong. I totally have no doubt about it.
So the nuance here is an occurring N2 versus an obvious.
And then why we send it? Why we are so? If you take an insular disease, 4.5 centimeter, you won't have a discussion. You discuss dena hai ki nahi dena hai ki. Here again I put the number. The number is almost 13 to 15% absolute survival benefit. Now that is what you are concerned about. If I am not able to deliver in those 40% patients, then I should be concerned. So answer is for 100 patients, not for individual, because if I say it is wrong, you say, hey, I was able to give chemotherapy, then I say it's perfectly fine.
So, yes, I have to comment. So, occurring N2 disease, if there is a single node less than 3 centimeters, that is one of the indications where surgery is actually beneficial for the patient. And the problem with neoadjuvant chemotherapy is that it's not perfect, so there might actually be progression on.
Well, there may be debate on that, but yes, occult N2 disease, occult word is the key to this. Next one, please. So, so we have certain data now which patients with unsuspected N2 disease, which is an occult N2 disease, do quite well with surgery. So this was a paper initially which came from Symposium's group in 2008, but the 5-year survival of unsuspected N2 disease was before complete resection followed by I agree, whether you are able to deliver the excellent or not.
So, I use survival of 30%. Why do you want to say this? Because if you think about it, I added, if the 60% of the patient who is able to get chemotherapy, it will be 35% plus 15%. If you are not able to give those patients chemotherapy, 40%, it is.
This was in a patient who has undergone complete resection followed by 20.
So there is a caveat there. So caveat, so if you are able to deliver chemotherapy, there's no question about it. That we give upfront or we give later.
That's why I mentioned your thing that your concern about
coming to Ajay's comment, Ajay, if progressive disease was a concern, then any N2 should not be. Why we said 35 is good, so 20 is also good. Otherwise, it will be 0. So, progressive disease, why people are not so concerned in LACP, where you have a chemoresponsive patient like breast cancer. You have a 7% patient where there is a progressive disease because you choose those bad apples.
No, but statistically, the benefit is more than the progression. So that's the reason why it
should be in places where the relation score is not available. It should be nearest patient with post-infusion would have probably required.
I have no doubt about it. If you don't have endoscopy, if you don't have PET CT, that doesn't mean you stop treating lung cancer. I don't think so. Your benefit is incremental. Benefit is not something dramatic. When we put this into
question is whether you are able to deliver post-operative chemotherapy. Next one is next.
But
it's a similar thing.
Ashwin, the last comment.
It's very fascinating to see that support study.
There are other studies also.
No.
This is from Japan.
So there were 13% of the patients who got radiotherapy. So my question as a surgeon for you is, do you think we miss small lymph nodes that potentially have capacity? These were not dissected. Or is there a possibility that is what defines survival, or would there be a hope for concurrent chemoradiation in this subgroup of patients?
So when we do a systematic lymph node dissection, we don't count the lymph nodes and remove. We remove a packet in this station. The whole thing is removed. So it is unlikely that we would leave behind disease there. Well, it is possible that there might be an N3 disease which is lurking there and we have not dissected that. That's a possibility. It is possible that there may be a mediastinal and retroperitoneal disease which is there, which we have not dissected. Those things.
But so I don't know if you are showing the next study where was there a concurrent chemoradiation done or just
No, this is the justification for doing surgery in an operative N2.
Right, but so following Gulf N2, is there a role for concurrent chemoradiation or we just talk about adjuvant
chemotherapy? Because the adjuvant radiotherapy, post-operative radiotherapy, we generally do not give unless there is a respiratory or a positive margin. Is that correct?
Well, so Durga, going back to the end was positive, right? Called positive. So at this stage, would you choose a chemotherapy or chemoradiation?
Chemotherapy. Chemotherapy. Because the role for post-operative radiotherapy for most of us is only in positive margins, and if we are left behind tumor,
Into this split randomized strategy.
next one is
We don't know why these patients get
next couple. This one answer.
I would like to thank all the delegates, Indraprastha Apollo Hospital, and all our sponsors. I think please we will see you later.
पेशेंस तो कभी आती है
सब वो लास्ट स्लाइड का